We are starting in 2 minutes. We are starting in 2 minutes. And we are now live online.
Today, we are here for more than just a conference. Imagine someone you love, maybe a young mother, an ambitious son, or a vibrant friend, facing one of these terrifying diagnoses. We're not just scientists, doctors, or advocates today. We are family, supporting our loved ones. Each breakthrough, every shared story, leads the path to hope. I invite my fellow patients and carers to join me at stage. Welcome to the second day of ENTERO.
Give a big applause once again. I want to thank you all for coming to ENTERO, for being the inspiration for us, for being our why, for being brave, sharing your experience, your journeys with us, and for helping others. For the others that are in the room, I hope now you see this is why we are doing what we are doing. And I want to thank you all for being supportive of this patient and care community. There are many of those that were not able to join us on the stage, but we hope to be able to bring them and also to remember those that are no longer with us. So thank you all. Welcome to ENTERO second day. Please take your seats now. And I hope that you can keep on supporting us. Thank you. Natasha, one more flower. So welcome to the second day of ENTERO. I hope you had a lovely dinner last night. I hope that you made some new friends. And now I will give the floor to Tihana Gaspar. I see Tihana. She will be taking you to the first session of this morning. Tihana, the floor is yours.
Good morning, everyone. My name is Tihana Gaspert. I'm an oncology and hematology nurse from Croatia, and it is my pleasure to welcome you to the session about early age onset cancer survivorship and long-term consideration. Today with us we have our experts along with our patients who will discuss these critical issues, especially related to the young adults. So I would like to invite Dr. Munir, our patient Lasma and Michael, and our first presenter, Johan de Munta, to come to the stage. So our first speaker will be Johan de Munta. Johan is a nurse manager at the Cancer Center of the University Hospital Ghent, and he is also a past president of the European Oncology Nursing Society. And Johan's work emphasizes the critical importance of holistic care, not just in clinical setting, but also in a broader context of patient advocacy and education. Welcome, Johan.
So thank you, Tiana, for introducing me. First of all, it's a great pleasure to be here with you. And like everybody of us, I could witness a very, very great day yesterday with a lot of great speakers and a lot of great presentations. But what really struck me was the screen in the hallway with the booklet that DICE is creating and will publish next year. And it's like all these stories in that book that means so much, and I think it's so valuable also for healthcare providers to read the stories and how you enhance and embrace life. But also what I was reading very much was also the struggles and also the barriers you will encounter in the way you have to move forward. So my name is Johan de Munter. I'm working as a cancer nurse manager in the University Hospital of Ghent. But I'm also past president of the European Oncology Nursing Society. I have no disclosures, and maybe not everybody is aware what is EONS, the European Oncology Nursing Society. And EONS is a pan-European organization that is developing of cancer nurses and cancer nursing across its member countries. So that means EONS has individual members, but also the national societies of each country of cancer nursing or members of EONS. And we also advocate around 32,000 cancer nurses across Europe. So our mission Our mission is as an umbrella organization and to ensure that all people affected by cancer benefit from the care of highly educated, well-informed and competent nurses. And also in the stories yesterday and also in the nice dinner in the evening, I heard already that also nurses play a big role, but also they're creating the barriers where you have to struggle with, and maybe there also need, and there is also a big need of education still out there. And if we're talking about young adults and adolescents and also in the survivorship, we need, and for myself, I put it in perspective. So that means if early onset, and especially in adolescents and young adults, that means they have a whole life before them, but at some point, were confronted with cancer and it stopped their life. That is something what we were reading, a lot of literature, but also in the research we did in our own hospital. That was something that always come up when I was confronted with cancer. It stopped my life and I saw all my age, my friends, my peers moving forward in another life and I was living alone at that point. So if we look into then the treatments, so we see in digestive cancer, like there's chemotherapy, radiotherapy, surgery, so a lot of treatments come along with that could cause also a lot of side effects, but also long-term effects that causes next and in the long term, in the last life, in the long life that people have to encounter before them. So, and when I was looking to this slide, I was thinking like, if you're talking about survivorship, when does survivorship start and when should we take survivorship into our care? And from my perspective, taking into survivorship is starting with diagnosis. Because survivorship is also all about like knowing your patient. Who is that person that is sitting before you? What has this person gonna need during treatment, but also afterwards? What do they need to move forward, to leave the cancer experience behind them and move as the best possible in front into their life with the best possible quality of life and the best outcomes. So that is something that is started, what I believe, at the beginning of a diagnosis. Know the person that is in front of you, know what their life goals are, and how we're going to encounter it. But also related to research saying the life is standing still, that is helping them move forward. It doesn't have to stand still. We have to move forward, incorporating, of course, treatment with the best possible outcomes. And this is something what we heard a lot of, I think, during treatment. As cancer nurses have a long journey to go with their patients. That is something we see. There are a lot of healthcare providers doing their best what they can, but mostly what you're reading is the experience that patients have. Despite all the people in the hospital, they're feeling much more alone at some times. And if you're talking about young persons in a hospital and young people, yeah, they have a vibrant life. They are in the life stage that a lot of transitions happening, a lot of happening is exploring themselves, moving forward, maybe starting a family, thinking about going to college, maybe thinking about university, looking for what they're going to do with their life, looking for a work, the profession, and at that point, you're feeling alone and you can't move that forward. And maybe that will be endangered even your goals, your life goals that you were setting in front of you. So for example, you're thinking of a kind of a profession, but because of the cancer, maybe this will be not possible anymore. Or maybe you didn't go to the education. Or by side effects, for example, you can't study anymore that best as before. So this is something we need to encounter, we need to take with us as a healthcare professional and provide the best possible care to let that moving forward, also during treatment, and support this for after treatment. So what does it mean being a survivor? And what we heard is also a lot that, of course, you're cured, and this is a milestone, and this is, of course, something that is very good, and it needs to be moving forward. But then, of course, we also need to talk about the side effects. And what I was already relating to it, that survivorship starts at the diagnosis, it's much important to also highlight this at diagnosis, to discuss this with patients, what can be on their pathway, so they can encounter with it, so that we can work around it, so they are not surprised at the moment when some long-term effects are occurring. So again, survivorship starts at the diagnosis. So, and if you're thinking about the long-term side effects, I was doing some research on this, and yeah, we see there are some specific ones next into the list of a whole long list of side effects that could occur for young people and adolescents that have received chemotherapy, radiotherapy, or surgery, and now even more immunotherapy with new kind of side effects that are occurring. But we see, for example, if you have still a long life, second malignancies or can occur. We need to prevent, we need to screen for it. We need to talk about this. Cardiovascular disease, because of the chemotherapy maybe and the long onset afterwards, we see more and more cardiovascular disease in survivorship stories. Endocrine dysfunctions, body disfigurements by surgery, for example. How are you going to live with it? How are you going to take up your life afterwards? Or maybe there is surgery needed to do something differently or make it okay again. But also the physical condition. And we know, for example, that fatigue is one of the most lasting side effects and long-term effects with patients confronted with cancer. And what in young people's life that needs to be active, vibrant, and this is also have a much more impact than just fatigue. It has impact on your physical being, it has impact on your psychosocial being, but also on your social life, and maybe also on your occupation. Talking about peripheral neuropathy, a very specific side effect that we see and how it can also have a lot of impact on their quality of life, but also, for example, on occupation, on hobbies, for example. What if you play music or playing music as a professional? And it's becoming and occurring on a long term. Is that still a career you can manage? How we can prevent this? And also this is a kind of, we can start at treatment is prevention by doing, for example, assessment, following up, talking about it in an interprofessional way and managing side effects from the beginning. But also pain, for example. More and more we see in survivorship stories that pain during treatment and after treatment can become chronic pain on the long term. And this will also demanding for support for patients that have chronic pain, because we know that chronic pain has a very damaging impact on the quality of life of patients. But also the issues in bowel movement, for example, frequency, urgency, and clustering, and then, of course, fertility and sexual dysfunctions, what will be discussed in one of the next presentations. Next to that, we see also the psychological distress, post-traumatic stress, what's keeping patients not moving forward in their life, but also the fear of recurrence. What in survivorship if you're constantly thinking that cancer can return? What are we going to do? How we can support you? And are these support systems in place? Is that something you can find where you were treated? Or is that something that needs to be installed by the society? Or, for example, if you're looking to Europe, how are we going to encounter the inequalities in supportive care across Europe? And also social education, employment, financial relationships. That is what young people are busy with, starting a family, buying a house. And we will hear more about it in the Right to Be Forgotten, how much impact it has on financial issues being encountered with cancer in your young life. All right. So if we look into the trajectory of patients, of course, we heard yesterday a lot about prevention, risk reduction, and we still have barriers there to tackle. But also, for example, in screening, in diagnosis, we hear the stories about how diagnoses are delayed, but also in treatment, and of course, survivorship care of end-of-life care. Also there are still some barriers and things to need to tackle for making the patient experience better and have better quality of life outcomes. And that's mean on physical challenges, cancer treatment related, how we can encounter them. Do you have access to a specialist nurse, a clinical nurse specialist doing your treatment, but also after your treatment? Do you have access to psychologists or nutritionists, or, for example, somebody from physical activities, or is there a rehabilitation program, for example, in your hospital settled where you can move in? But what also after a couple of months or after a year and you experience again long-term effects, where you can go, and that is also a struggle that a lot of people struggle with, like, who can I go for support this? So mostly then also the general practitioner coming in place, but is he always or she always aware of what is happening, or what these long-term effects means in survivorship? So that's something we see that also as cancer nurses, we think about, like, for example, survivorship care plans to install it, to also transmural communication to the first-line community care settings to support patients in their survivorship story. But also thinking about the psychological changes, social changes, and we need to think about the healthcare system. How are we going to move the healthcare system that makes place for this new type of incoming services that we need? Because luckily we see more and more survivors in cancer, and that's a good thing. But that means we also need to take care for it. It's not just acknowledging it, it's also taking action and put these survivorship actions in place. As I see my time is up, I need to speed up a little bit. So the challenges are, I think we heard already in prevention, but also in prevention in the survivorship trajectory. So more care that we have less cure to do. Screening and early detection in early onset of cancer, rectal cancer. The survivorship burden we have to take, not only the physical things, we need to take care of also the psychological things. And we need to think about long-term follow-up guidelines. How are we going to follow up? How are we going to implement this survivorship and treatment plan? And how are we going to take, for example, first-line and community services into it? Because, for example, in Belgium, also we see like colorectal cancer can be treated, or some parts of the treatment are at home. But that needs also that, for example, home care nurses needs to be informed, needs to be educated to provide you the best care at that moment and also help you into make shared decision making. So that means healthcare organization is a very critical part, and how we're going to move to the future to put in that survivorship services. So what I want to conclude is comprehensive, individualized approach to treatment-related long-term side effects in early-stage colorectal cancer needs to be balanced between active cancer surveillance with quality-of-life improvement efforts that need to be set, for example, from start with treatment to long into the survivorship trajectory of the patient. So also addressing the impact of treatment decisions, it needs to start early to talk about quality of life and incorporate it in survivorship. We need to talk about like holistic survivorship care. So more and more we're working more in interdisciplinary way, also in hospitals, but it needs to continue after the treatment, also long time in survivorship. And of course, there is an urgency in survival experience and outcomes, and in particular in models of care and addressing inclusiveness and health disparities also for adolescents and young adults with cancer. And how we can tackle this burden, I believe we can do it by interdisciplinary training and education, research and development, leadership and management, and, for example, care coordination, but not without patient and public involvement, because the voice of the patient is something that needs to guide healthcare professionals to provide the right quality of life for all of us. And I think the best way to improve cancer care for all is to put it together. So thank you very much for your attention.
Thank you, Johan, for your presentation. It's very important to talk about long-term side effects and how we can be a burden to patients, and what we can do as a healthcare professional to educate ourselves about those long-term side effects and how it affects the patients. And we need to work together in treating those side effects. So now it is my pleasure to welcome our next speaker. It is Professor Ben Aharon, who will be joining us virtually. She is a leading expert in fertility preservation and reproductive health for cancer patients, with a focus on the unique challenges faced by young individuals. She will be discussing the critical topics of fertility, pregnancy, and sexual health in the context of early onset digestive cancer. Let's give her a warm welcome.
Thank you so much for the kind invitation. I'm so sorry that I cannot join you in person. The EROTC meeting is exactly on the same time. I want to congratulate ENTERO and DICE for this beautiful opportunity to really give another perspective that I think we lack, and I think that intensive participation of the patients and survivors can really augment what we are doing in cancer care and cancer research. I will share my screen. Just let me know if you see it and if you can see that I'm moving the slides. Okay, I see it. First of all, I will introduce myself. I'm the head of the Cancer Center at Rambam Medical Center at Haifa and PI in the Faculty of Medicine in the Technion. And since 2017, I'm chairing the Young Onset Cancer Task Force in the EORTC organization. In my background, my main research is on reproductive and developmental biology and toxicities of anti-cancer treatments, especially in young population. As you've heard, the early onset cancer is on the rise. We can see that, I see that my slides are not coming. You see my slides?
Yeah.
Maybe I'll do that again. Please let me know if you see that the slides are not running.
We can
For
see
me, they're running. So we know that early onset cancer is on the rise. We know that early onset colorectal cancer is specifically on the rise. And if we look at the WHO database, we see that the future does not seem any brighter. And the incidence of early onset colorectal cancer is supposed to increase more and more in the next years. We know that the younger generations or the younger ages, we can see that the incidence of colon cancer and rectal cancer are even rising below the age of 35. So this is something that brings us many perspectives that are not the typical ones that we deal with older population. And in 2017, we in the EORTC decided that this is a very, very important topic. It was not on the hype like now, but we decided that we are going to launch a specific designated task force for young adults. And the strategy was really to study the trends, to see if something that is supposed to be environmental, whether the specific etiologies and the trends are unique in specific geographical places around the world. We wanted to study that, to generate discussions, a tool on practical issues for young adults, and also to create innovative research tools, and also to involve patient advocates. And on this talk, I'm going to emphasize mainly on specific side effects of treatments with a focus on the reproductive perspective is a key one. And when we look at the ESMO guidelines, ASCO guidelines, all professionals guidelines with regard to fertility preservation, we know that there are standard ones such as embryo or oocyte cryopreservation. There's also the ovarian transposition that we recommend to any patients that female patient that should undergo radiation to the pelvis. And there are some experimental pathways to preserve the fertility. One is to preserve ovarian tissue, which is still considered as experimental. And the other one would be to suppress the ovarian function, so it would be silent, and then maybe the treatment would not damage the function. But we have a lack of evidence on colorectal cancer patients, and this is a key issue. When we look, for example, on ovarian suppression, there is a treatment that is called GnRH analogs, and this is something that is very common in breast cancer patients. What we do is actually we suppress the ovarian function in these patients, and then we have a very low hormonal state. But when we look at the studies that really looked at the action of GnRH analogs to preserve fertility, we can see that all of them, the ones in red, are in breast cancer. The one in green are in hematological malignancies, such as Hodgkin's lymphoma, non-Hodgkin lymphoma, and the rest are in ovarian cancer. And there is nothing actually about colorectal cancer. And it's not a universal effect, since The role of GnRH analogs is when we look at the circle of hormones from the brain to the gonads, to the ovaries, and there is an extraction of hormones, and those gonadal hormones are being released from the brain, from the pituitary gland, and they actually impact the ovaries to produce the hormones, to produce the menstrual cycle and the maturation of the oocytes. And what the GnRH analog actually do is actually they keep this axis, the hormonal axis, silent. They produce an artificial prepubertal state, like in adolescent, or before that, we don't have a regular menstrual cycle. And by that, it is presumed to keep the ovary from the toxic effect of chemotherapy. But it's not that any chemotherapy induces the same toxic effect on the ovary. It depends on the type of chemotherapy. Some chemotherapies actually affect directly the ovarian follicles, such as cyclophosphamide. This is Cytoxan, the agent that is being given mainly in breast cancer. But for example, anthracyclines, doxorubicin, adriamycin, they are being given also in other malignancies, such as breast, but others. They induce the toxic effect by other means, such as affecting the blood vessels of the ovary. And when you give GnRH analog, it's supposed to reduce the toxicity of the chemotherapy on the ovary, but it depends on the type of chemotherapy. For example, when you give Cytoxan, then the GnRH analogs are indeed protecting the ovaries from the cytotoxic effect of this drug. But when you give that with another agent, such as adriamycin, it does not have any effect with regard to the effect on the vessels. And that is why it is not quite effective in that setting. And when we ask ourselves, what about oxaliplatin-based protocols, such as the ones that are being used in GI malignancies, we don't have any idea. We actually don't have any evidence, not even single study that was done in colorectal cancer patients, not even in the preclinical setting. So when we have to consult today a young female patient, do we need to give you GnRH analogs? We don't have any evidence to do that, and that is a problem. When we look at what there is in the literature regarding what those protocols of colorectal cancer, what it does to fertility, we can see that there are some studies, very small ones in terms of the sample size, indicating that there is an effect on fertility, but that effect is less pronounced, for example, than the protocols that we use, for example, for breast cancer. Another issue is radiation. We give radiation for rectal cancer, and the data that we have on the effect on the uterus, for example, is very limited, and it relies upon survivors treated with abdominal radiotherapy when they were kids or adolescents, and we can see that the risk of delivering offspring that is with low birth weight is higher with patients that received radiation, but we don't know anything about the impact of the new technologies that we have and the new techniques that we are using for rectal cancer, which is and the field of radiation, which is very different from the ones that we give to childhood malignancies, such as Wilms tumors and others. And we cannot really compare the effect of radiotherapy on a larger field to the ones that we give in rectal cancer. And that is really a problem because, again, we are facing those patients asking us, would this affect my pregnancy potential? And we don't really have the right evidence to give the right answer. What we do know is that there is a way to protect the ovaries, to protect the oocytes, and that is to transpose the ovaries. The ovaries are an organ that is on a specific stock that enable us to divert them, to really transpose them very easily in a laparoscopic manner to outside of the pelvis, outside of the radiation field, and that is very safe, and this is something that we do routinely. But when we look at the literature to see what is the effect of radiation on the uterine toxicity, what is the effect of chemotherapy on the uterus, we see that most of the studies on chemotherapy are using cyclophosphamide, again, the one that we're using in breast cancer, but not in colon cancer or rectal cancer. And the studies that follow the effect of radiotherapy, again, is only very small studies on childhood cancer survivors, adolescent cancer survivors, which we don't see the same radiation field, not the same radiation technique. It's very hard to draw conclusions on that. A trend that appears to pop up in the last few years is maybe to transpose the uterus before radiation. What they do is actually they cut the uterus before radiation. They put it and position that on the umbilical, on the epigastrium, on the umbilical trocar, and they keep it out of the radiation field. Then after they complete the radiation, they can put back the uterus there. And there are some reported cases, and recently a live birth in a sarcoma patient. But other than that, it's very experimental. And it's very hard for us to really know what is the mechanism of radiation-induced toxicity on the uterus in those techniques that we use in rectal cancer. And we don't know whether the effect of radiation on the blood vessels of the uterus is going to be the same if we use the ones that were radiated after cutting it and transpose the uterus and then put it back. We don't know whether the physiology of the uterus during pregnancy, following the fact that it was cut and repositioned into radiated area, we don't know the effect. We don't know if it's going to be safe. We don't know what are the complications of this procedure. These usually are curative intent. These are patients that we intend to cure with the treatment. And if something goes bad because of this operation, it's not a good idea that those patients would later on had to really postpone the treatment. And at the moment, since we don't have the answers to all these questions that I've raised, we need to consider that as an experimental procedure under an experimental protocol, under research. And only once we see that this is safe, that it did not increase the complication rate of rectal cancer treatment, then maybe we would be able to take it as an alternative. Now it should be considered as only an experimental protocol. Some words about colorectal cancer during pregnancy. Since today there is a trend to delayed childbearing age, and we have an increase, a substantial increase in colon and rectal cancer in young adults. The situation that we have a colorectal cancer patient that is diagnosed during pregnancy is getting more and more frequent than it used to be in the past. It used to be a very rare situation, but now we see it. If we look at the literature, we don't see many descriptions or many reports of these patients. We have several studies which are case series in which what we know is that prescribing the treatments that we use for colorectal cancer during pregnancy supposed to be safe. There was a nice overview in a paper published last year in Lancet, indicating that if we look at the maternal complications, we see that there was the rate of maternal complications, such as preeclampsia, was higher in the women that were diagnosed with colorectal cancer during pregnancy, compared to women that were controls without cancer. And we can see also that more of them appeared in an emergent situation. When we look at the neonates, we can see that more were in preterm, 12% compared to 5% in general. And we can see also that some of those complications in the neonates were due to prematurity. What about sexuality? Again, we have many studies conducted in breast cancer patients, hematological malignancies, prostate cancer, not so many in GI cancer. But we do know that if we look at the psychosocial effects about the chemo brain, the memory deficits, the coping, the chances of getting back into social activity, coping with children, we can see that there are significant struggling and challenges in this population. And also with regard to sexual function, we can see that if we compare them to the GI cancer young patients, we compare them to breast cancer patients and to prostate cancer patients, the sexual function is an issue that is significantly even more serious in this population. And in this review from last year, we can see that in some of the studies that really investigated this population, we could see that they had worse body image, worse sexual dysfunction, a problem with their intimate relationship, and this goes along all the studies. So what we have to do in order to really improve the situation is to really enhance the supportive care for our patients. We, in several places around the world, have designated services for early onset cancer. And in this specific program, we need to focus on the specific, the unique perspective of each cancer type. The ones of GI are very much different from breast cancer. We have in our center a very nice OncoYoung program, and we look for to know the patient satisfaction rate, and we saw that they really like this program. We also use patient parliament every 3 months to to involve them with their perspective and their ideas. And actually, we revisited 50% of the concept of the paradigm of what we are doing upon the ideas and the concept of our patients. And this is something we are very proud on this collaborative effort. We also designed a comprehensive curriculum, a national one, which is called the Approach to the Young Cancer Patients. The target population is physicians, nurses, social workers, physiotherapists, anyone that really is in this loop of treating young cancer patients. And we created a formal teaching module on young onset cancer patients in the National Professional Course for Nurses in the Ministry of Health. And this is something that is very successful and has been going for 3 years, and both the staff and the patients are very happy with it. So to conclude, early onset GI cancer or colorectal cancer, which present the main majority of this entity, is an unsolved puzzle. We need to look for the etiology. I didn't get into that. It was not the topic of the talk, but certainly when we have cancer that is rising in young adults and most of it is sporadic, we need to really look for the etiology, the geographical, ethnical differences. What is the reason it is rising in the past 3 decades? Again, toxicities is a major issue for young cancer patients. It's so important to really try to reduce morbidity of later years. Psychocognitive function is key for young patients to go back to their life. And I think that today it's not a privilege to talk about quality of life, about the future. And patient engagement and involvement is a major thing. And this is something that we have been doing in the past years and recently, and trying to really promote this collaboration, because this is going to be something that we are all going to make a huge impact from. So just to mention that there is paucity of data regarding fertility preservation techniques, but also toxicities, as also was brought in the last talk. I think that we should gather patient organizations to really look for the evidence, because still the number of patients per site, per hospital is still very low. So we need to do something that is very comprehensive and cross-sectional to get the data. There are many perspectives that we need to follow, the many challenges that we have, mainly with young patients. But I think that it makes the future much more interesting. Thank you.
Thank you, Professor Ben Aharon, for highlighting the importance of this having access to comprehensive information on fertility and sexuality, and supporting patients into the survivorship trajectory on this, because we know, for example, from research that fertility provides the perspective of hope, and that is very important for all patients. So, and we know that knowledge is essential also for healthcare professionals and patients, to support them and to empower them to make informed decisions and supporting during their cancer journeys. So thank you again for this highlighting presentation. And before we moving forward to our panel discussion and the questions we have last presentation from today, and we want to dive deep now in the financial and economic challenges that cancer survivors often encounter. And that is something we see a lot, and we're reading a lot about financial toxicity in cancer survivorship stories. So the crucial topic of not the right to be forgotten, and we have the privilege to welcome Dr. Françoise Monnier, the founder of Ending Discrimination Against Cancer Survivors, and Dr. Monnier is a dedicated advocate, we can say, for cancer survivors' rights, working tirelessly to raise awareness and address the discrimination they face. So Dr. Monnier, please, the floor is yours.
Thank you, Johan. First of all, I would like to thank DICE for inviting me to this very important and very inspiring meeting. Thank you. I am extremely grateful for this. I was graduated as a medical doctor in 1974. At that time, many of you were not born. And at that time, it was a death sentence. To announce diagnosis to a patient in 1974 was a death sentence. And therefore, I dedicated my professional life to the improvement of survival and quality of life of patients with cancer. I officially retired as director of URTC in 2018, and since that time, I dedicated my time to professional activity related to the right to be forgotten, that is, ending discrimination against cancer survivors. As I am retired, I do everything pro bono since 2018, so I have no disclosure. There is now life after cancer. Thanks to the tremendous progress in molecular biology, in cancer therapy, we can provide hope to the patient. And indeed, there is light and bright at the end of the tunnel. Today in Europe, there are 20 million cancer survivors. And this is going to increase, we know that. And so the number of patients who will face, and survivors who will face financial toxicity is really important. And I feel that it is a duty and responsibility of the whole society to make sure that when we medical doctors tell to a patient that he is cancer-free, cancer-healthy, that he is cured, he is not penalized by the society for getting access to financial services. Cancer patients should not have to pay twice. And indeed, there is light at the end of the tunnel. It is a tremendous thunderstorm when we announce the diagnosis of a cancer to a patient. He has to go through heavy rain during the cancer treatment. And at the end, there are still numerous issues, like we have discussed, and Johan has presented all of them, in the survivorship. And what I wanted to focus is on one of them, which is financial access. And this starts back in 2014, when at the European Parliament, with Marc Loller, professor in FAST in Queen University, we signed an European Cancer Bill of Rights, which was really important to establish what are the key recommendations for providing rights to the patient. This was in 2014. In 2014 was also the year where I organized the Survivorship Summit. I did 3 in 2014, in 2016, in 2018. And in 2024, I had the pleasure to organize at the Royal Palace of the Academy in Brussels, the high-level conference under the Belgian presidency of the EU, with the presence of 2 EU commissioners, Madame Kyriakides and McGuinness, who were really responsible to try to establish a legal framework on pan-European level for the right to be forgotten for cancer survivors. And that was the official recommendation at the end of this conference under the Belgian presidency. Where do we are today? Today, I am working on 2 aspects, EU, which I will discuss later, and member state by member state. If we look at the European map, there are now 8 member states who have a legal framework, who have the law to make sure that when a patient has been cancer-free, cancer-healthy, cured, after a certain delay, whether it is 5 years, 7 years, 10 years, and it keeps moving and adapting, the patient can now have access without discrimination, cannot be discriminated by insurance company to get loan and mortgage. This financial access is really important for young person who are facing colorectal cancer or whatever cancer, because it's at that time that they need to start back their life, to get a loan, to get an apartment, to get a mortgage. This is really at the time you need it. It's not when you are 70 that you need a loan to get ready in your life and you buy your apartment. So this is really important. And if we want to look at the national legislation, France was pioneer. They started in 2016, and that was where I got my inspiration, because working at the pan-European level for so many years, I said if it works in France, it should work in all EU citizens. And it is not normal that not all EU citizens would benefit from the right to be forgotten. The law have evolved. They start with 10 years delay, then they desescalate. It's now 5 years in France, and as January 2025, it will be also 5 years in Belgium. There are some discrepancies, and it's normal. We can live with national specificity, for example, the amount that you can get in a loan, because the cost of housing is different in different EU member states. For example, in Belgium, there is no upper limit. In Netherlands, the upper limit is 270,000 per person. So that we can live with, but the general principle of the right to be not discriminated and not to be refused by insurance company when you want to get a loan is really important after a certain period of time. What is important to know also is that there is exception grid, and that is a list of cancer with better prognosis where the delay is even shorter than the 5 years. For example, thyroid cancer, very small breast cancer, and so on, can be 1 year delay, 2 year delay after the end of treatment. And France is even paving the way further, because now there is Crédit Mutuel, which is one of the largest insurance companies in France, which abandoned the medical questionnaire for loans up to 200,000, which is really important, because if you don't have medical questionnaire, by definition, nobody knows whether you had cancer or not. And another company also, CNP, which is another large insurance in France, decide to not put any delay for breast cancer after treatment. That are all major steps which show us the way, and what I am saying to each country is don't reinvent the wheel. We know that it's functioning. Since 2016, there is no insurance which are bankrupt in France. So if it's work in France, it should work for all member states, and that's what I am pleading for all countries. What is really important is that Netherlands follow, Portugal follow, Romania follow, Spain, Cyprus, and Italy. But what I want is each member state, so I am working member state by member state. We are now negotiating with Malta, Germany, Slovenia, Finland, to try to make sure that we make progress and provide this to all EU citizens. What about EU? It is an EU competency because, well, health is not an EU competency, it's the member states which are relevant. But discrimination for access to financial service is an EU competency. It is in the EU Treaty, it is in the Charter of Human Rights, it is in the Treaty of Functioning of the EU, so it is indeed a matter that can be dealt with by the EU. And we successfully put the right to be forgotten within the European Beating Cancer Plan, but the survey made by the Commission to the Member State authority showed that there was a major block from insurance company, and they did not want a legal framework, but a code of conduct. I must say that I don't like a code of conduct. I will never sign a code of conduct because it's not binding. That means that that or nothing is the same. The company can still do whatever they want. It's not binding, and it has to be transposed by member state. And they don't agree with the 5 years delay. Now there is the cancer mission. In the cancer mission, they also succeed to put the right to be forgotten in the recommendation, and the mission board members who are directing the research at the EU level are trying to put it in member states because they have created ambassadors in each country, and they try to convince also each country to reach a right to be forgotten. The third point is the Consumer Credit Directive. The Consumer Credit Directive has been revised last year. Unfortunately, again, the right to be forgotten was included in it, but the insurance company put the deadline of up to 15 years after treatment. You realize, up to 15 years after treatment, which is unacceptable. Now, with the new Commission, we are waiting for the revision of the Mortgage Directive, and that is going to be also a major issue where I will really be vigilant to make sure that we try to convince them to base their experience on the existing system in 8 member states which are functioning. What is needed is innovative solution for appropriate rehabilitation. Johan showed very well, and the previous speaker as well, all the different side effects. Concerning financial services, full reintegration into society is really important. And for that, we need to convince insurers. And to convince insurers, we need data. So the collecting of data at the European level and having adequate registries showing the survival rate, which is moving and moving fast, and with a lot of hope, is really important. And the final goal is to get an harmonized legal framework throughout EU, even if we can accept some national specificities. And I am an optimistic and a fighter, and time will pay off. In 1909, when Blériot crossed the channel with a little plane which was totally rudimentary and unsophisticated, nobody could believe that in 1969 the man would be on the moon. Yes, it took 60 years, but I was at the EU level. you can have many more information on the website that is here, Ending Discrimination Against Survivors. And what I think is that testimony of patients are the most important element to convince politicians. And you can see on the website there is indeed the patient testimony, patient stories, and that are really important to convince for the need for the society to change. Thank you.
Thank you, Dr. de Munier, about talking about right to be forgotten, which underscores the long-term effects which our survivors faced when they try to reclaim their lives after the illness, and how they face the stigma after they face illness. And this very important presentation is a reminder for us that while medical treatment is very crucial, we also have to take care about the holistic perspective of the patient and their needs when they try to go back into their normal lives after treatment.
Okay, thank you very much, Diana, and also thank you very much for guiding us so far in this session, and also do the moderation.
Oops.
Okay, everybody is okay.
No, it's my
But I think that brings us with the remaining time we can use to answer your question and go dive deep in the discussion on these important topics with all of you. But before we're going to do this, it's my honor and pleasure to introduce two special guests here. It's Lasma, welcome to the floor. Michael, welcome to the floor. Please give them an applause. So for the discussion, I think your personal stories and insights will be a tremendous value to deep dive in the topics we're going to talk about it. But I think it's very important we firstly going to listen to you, who you are, and maybe you can introduce yourself and highlight a little bit of your own story. So I should suppose, like, Lasma, we start with you.
Okay, yeah, we can start. Can you hear me? It's working, yeah?
We can.
Okay. Hello, everyone. My name is Lasma. I'm from Latvia. And 5 years ago, when I was 33 years old, I was diagnosed with stage 3 rectal cancer. Regarding diagnosis, my story is not unique, because due to my age, of course, doctors didn't suspect cancer, and it took some time. But once it was diagnosed, things moved on very quickly with neoadjuvant chemo and radiotherapy. Everything happened so fast that fertility preservation was not even mentioned in my case. And since it was bowel cancer, also I didn't even imagine that radiotherapy could cause early menopause for me. And it came as a surprise in the middle of the treatment, of neoadjuvant treatment. I realized that I'm starting to experience something like menopausal symptoms, and I went to my radiologist to talk about it, and she honestly admitted that she forgot to tell me about it because she wasn't used to treating young patients. Yeah, and after the neoadjuvant treatment, I undergone rectal surgery, I had temporary stoma, then adjuvant chemotherapy, and everything ended with stoma reversal. And that was the point when my journey with pretty severe bowel issues started. Everything you can see listed under the term LARS, like frequency, urgency, clustering, tenesmus, it all became my daily reality. I just became toilet dependent at that time. Yeah, and also after the treatment, I started to take hormone replacement therapy with the hope that it will improve my quality of life. And it really restored my hormonal cycle. And I took it for 1.5 years. And over that time, I realized that my bowel issues in terms of continence, especially during the night, became worse and worse. And through my own research, actually, I found out that this medication could be the cause for that. And I went to my gynecologist and asked if we could try to change the treatment, and we decided about hormonal contraception instead of hormone replacement therapy. And it really worked, actually, because my menstrual cycle still stayed stable, but it reduced those issues with the continence. But still, my condition was very, very far from something that could be called normal. So for the first 3 years after my treatment, I had no idea what LARS is, because none of the doctors mentioned it to me, told me about it. The first time I learned about it was when I became a patient advocate and I met other patients from other countries. They told me about it. And once I got the name for my condition, I could start targetedly research for the information. I found other patients and I could learn from their experience, got some tools how to manage my condition, and also I could start to advocate for how important it is to have a professional help from healthcare professionals to sort out the diet, to use the medication properly, because until then, the only advice I got was to be patient and to wait. Wait for 1 year, 2 years, 5 years, and to take loperamide if needed. But that's not how it works, because when you need loperamide, it's already too late. You have to take it before you need it, and then it works. So since then, actually at the moment, I can say that with all these tools, with all the information, I'm also, with the support from DICE, I'm preparing educational material for patients about LARS. And I intentionally involved doctors to help me so that I would raise awareness about this topic in my country that way. And with all these tools I have now, we've sorted out diet more or less, we've properly taken medication, I can say that I'm doing pretty well at the moment, but according to LARS scale, my LARS is still evaluated as a major LARS. So you can imagine that before that it was like major, major, major LARS, most probably. But I'm happy that times are changing, and in my country, for example, starting from the beginning of this year, it's mandatory to inform patients about the fertility preservation, and with the decision of doctors' council, it's also states funded. And if I still have time, I can add just one advice to doctors. Building upon what we talked already yesterday, please talk to your patients. Talk about these issues, talk already before the treatment, because it's much easier for me to accept that I will not have children, that I will most probably live with LARS all my life, but it's so hard to accept that I didn't have a chance to participate in the decision-making process, that it was not my decision, that everything was done without me saying, yes, let's do that. And it's so hard that I wasn't informed, I wasn't prepared before the treatment of what is going to happen, so everything came as a surprise, and most of the things I had to sort out myself. That's why I would encourage doctors. I know that I have talked to them, and they say that they avoid talking about after effects because they are afraid that patients would refuse treatment. But I know that the treatment saved my life, and that's the price I paid, and I would never blame my doctors for the after effects I have. But it's not acceptable that I wasn't a part of the discussion about it, and I wasn't prepared and informed before. That's why I would encourage all the doctors to talk openly with their patients and to treat patients as an equal partner of the discussion. Thank you.
Thank you, Lasma, for stepping up and advocating for it, because I think that means a lot for a lot of patients. So thank you very much for sharing your story with us. So, Michael, the floor is yours.
Thank you, Johan. So I think I will start with my recommendation because it fits very well to yours. HCPs, nurses, caregivers should talk to their patients, but also listen to their patients at the same time. So that's my general recommendation, to start with that. So I would like to take you back to the year 2018. This is where I had some problems with my bowel, with my digestion. I was 28 at that time, yeah, you know, I wasn't really a very, I would say, healthy eater, so I had on and offs of my digestion, so I would like to, you know, brush it off. It would be better. At some point, I could only go to the toilet if I would raise my legs. Otherwise, it was like a little bit difficult to defecate, and then I finally took the courage and went to my general practitioner, of course, and then he said, well, you know, you might have been eating a little bit unhealthy. The red color you saw in your stool might have been due to hemorrhoids or whatever. You know, you shouldn't be afraid, you shouldn't be alarmed so much. I was like, yeah, okay, let's take the cream, let's try it, you know. And then I came back to him, and wasn't the red color was still there after 2 or 3 months. And he said, well, yeah, maybe it could be bleeding from like from the digestive system. You shouldn't be alarmed and so ever. So back then, I would have been like appeased with that. But I was used to work in oncology at that time already, so I had this awareness that this could be also something more severe, right? This is a red flag, having blood in your stool, and so I went to a second caregiver, getting a second opinion, and he said, well, okay, if you want to have a coloscopy, if you insist, okay, I will write you the transcription, but you might have to pay for yourself because you're so young, so you should think about it if you should really do it, you know. And I said, I have to do it. I want to have this peace of mind. Back then, I was a father of a very 6 months old daughter, so we wanted to start as a family, and boom. So when they tried to do the coloscopy, they couldn't even get through. The cancer grew so big, so they had to stop the coloscopy. They had to make an emergency procedure. It was stage 3B colon cancer, so only like a moment before metastasizing, 15 of 20 lymph nodes were already infected. So yeah, they resected 30 centimeters of my sigma colon. I had to do 14 cycles of adjuvant Folfox chemotherapy. And this changed my life completely, of course. So it was at a very difficult time for us because we wanted to marry this year, actually planned our wedding. Yeah, as I said, my daughter was only 6 months old. But at the other hand, it helped me also to push through because I had something to, I had a mission, you know, I wanted to get healthy, wanted to become a family father and make this dream happen. Without any hesitation, I would go to the chemotherapy, and I would also do some sports at the same time, even though I was feeling sick and fatigued. So that helped me also a lot. Yeah, and after the chemotherapy, during the chemotherapy, I had this neuropathy syndromes. They grew stronger and stronger each cycle. So that was one issue I had to still dealing with today. So this is like the feeling hasn't returned completely. And then after chemotherapy was over and normal life, so to speak, went onwards, I tried to buy a house. Of course, the insurance refused. You know, they want to have a medical background check. And even now, after 5 years have passed, you know, I had this severely disabled card. Now, after 5 years in Germany, if you're not dead, you are healthy again. They call it Heilungsbewährung. You know, it's done. But the insurance companies still think I could die any moment, so they wouldn't give me any credit now. Yeah, so that's my story. Thanks for listening.
So I think, Michael, your story highlighted the importance to listen to patients and taking also the signs and symptoms seriously, and not just thinking like, oh, young people, cancer, mostly elderly disease, will not occur. Mostly it's not cancer, but if it's cancer, I think there is an urgency to act as soon as possible to have the best outcomes for all patients. So thank you for sharing your story with us on this one.
Thank you for this opportunity. Also, thank you to the DICE and the ENTERO Congress.
So I think now we have time for questions. So we want to open the floor for questions. And if there are any questions, please raise your hand. And a nice lady will join you with the microphone.
Maybe we can also ask questions.
Yes.
Hello. Thank you so much for the conference, and thank you so much, Laszlo and Michael, sharing. My question, I am Natalia. I am also a cancer patient, stage 4 gastric. I thought it was extremely interesting, your talk, Dr. Francois, about the right to be forgotten. And as somebody who is navigating how to go back to work and how does that work, and I would love for you to explain a little bit more what it means and what is the right to the patient in those moments when you are starting a conversation with a potential new employer, or when you're engaging on those conversations, because from an ethical point of view, sometimes I feel like I need to be disclosing everything, but at the same time I feel like if I disclose everything, then there's no chance I'm gonna get the job.
I am not a specialist of return to work. As I explained, there are specific issues require specific solutions. So I decide for myself to tackle financial discrimination with insurance. There are organizations who are helping cancer patients and former cancer patients to get back to work. And that is the name Work and Cancer, Cancer and Work. In which country are you? In UK, you have Cancer at Work. You have a strong organization who deal with that issue. But personally, I think we need to dedicate our strength to a specific issue in order not to dilute ourselves. All the issues are important, but cannot be solved at once by a magic stick. And so you need a magic stick for every issue.
Hi, I'm Patricia, and I'm a patient advocate. And just to, maybe not like a professional answer, but more like an advice for someone who also was coming back to work, you don't owe anyone anything. You don't have to disclose those stuff. Like, it's okay to take a sick leave at work, to go to see your doctor. Probably in the meantime, someone will find out or see, especially if you're a patient advocate and you are a little bit more visible and recognized and among the patient community, someone will eventually see the work that you are doing and kind of connect the dots. But you have to remember that you're just fighting for yourself. So you don't need to disclose those information. Still, I think it's also like a confidential information about your health. And if you feel like you want to come back to work, just fight for it and don't feel like you own anything to anyone, because you have every right to come back to work, and it's even like awesome because you're just trying to get ease into the society, like back and to old new life. So just try to remember to fight for yourself and don't worry about it too much. And still, I think that like the employer, those who has workers, exactly, I'd never know. They are like used to people being on a sick leave because it's natural. If you would have a cold, you wouldn't even think about saying someone, or like having a flu, or I don't know, like asthma, which is also like a, the chronic disease. But with cancer, I was like, oh my God, should I say it? And I had the same issue. And honestly, I haven't said. They just found out somehow because I was doing some advocacy work. And they were like, okay, great. And if you don't feel well, just tell us and we will try to work around it and find a solution. So just remember about your well-being is the most important here.
If I can respond on reaction, I think you're right, you don't own anybody anything to say, but I really think you shouldn't do that fight alone. I think there is help outside there, and also we need to invest in help outside there. And maybe it's not your employer you need to talk, but maybe there are services next to your employer, like for example occupational health services, back to work coaches like we have in Belgium, for example. But also it starts already with your physician, with your healthcare team. Maybe they can write a letter to these occupational services if you don't feel up to do this and to explain what is happening, how it can be that maybe you need for temporarily maybe adapted work, how we can improve this. I can imagine if you're struggling with large symptoms that of course the urgency, how are you going to do that at work if you were expected at some time to be? So I would really to advocate is you don't have to do this fight alone. please try to do it or find some help. And of course, it's not finding help, we should say, it's we should be offering help, and healthcare system should be help in place to do this. So really, we need to do this together. That is, I think, very important in this case. But we had another question, I think.
Yeah. Hi, my name is Mia. I'm from Helsinki, Finland. And I've been syndrome and I've had several cancers. And at that time when I got sick first time, I didn't get any information with my own language, and we have gone far. After that, we have patients kind of like diabetes and things nowadays, and I was the only one who was doing this lovely writer crusade for many, many years. Now we're getting connected, and thanks everybody that I've met here today. I'm really happy about it. I have so many questions, but one thing first is quite often other lynchies in Finland, they ask about how about my life insurance and my mortgage loan insurances, that are you supposed to tell, even if you haven't got cancer, that you are diagnosed because your family history, you have, for example, some kind of genetical mutations like Lynch syndrome, for example. Are you supposed to tell the insurance companies that you have some gene faults, because everybody's got something wrong somewhere, but basically where do you draw the limit? And also usually people mention that it's 5 years after you're so-called clean from cancer, you have to have another 5 years to be able to get a life insurance or mortgage. Is that really with also, for example, with lynchies who hasn't had any cancers, are you supposed to tell them that you're a lynchy? Can they ask that? Is it legal?
You cannot lie to an insurance. You have to fill up the medical questionnaire, but the medical questionnaire normally cannot ask for DNA results and genetic analysis.
That's what I meant, yeah.
No.
But because if you haven't had any cancer, are you supposed to tell that you have Lynch syndrome? Are they allowed to ask it? Yeah. So it's not allowed, basically, yeah.
It's not allowed to ask.
Yeah, but if they ask, can you say that, no, I don't have any? That's the thing, because they can go around it and you know, try. Sorry? Yeah, yeah. Okay, but, well, I have too many questions, so I just keep it in this for now. Sorry. Yeah. Thank you.
But we are still around here, so if you have any questions, you can approach each of us, I think.
Yes, of course. Yeah, hi, my name is Cecile, and I'm based in the UK. And I just wanted to pick up on something that Michael said. He mentioned exercise. And when I first was diagnosed, I was living in New Zealand, and the treatment center I attended had a little pilot initiative where we had the support of personal trainer to help along chemotherapy. And I've since had recurrence and several courses of chemotherapy, and in between you feel really alone. You know, there's no support. You've got a few follow-up appointments, but it's pretty limited. And I found exercise has really helped with mental health and getting the muscle back and feeling yourself again. But it's hard getting back into it. So I think there's scope for a bit more support there. And maybe, I don't know, Johan, are you aware of any initiatives, or is there any discussion? Because, I mean, from my perspective, you know, from being in the UK, I've never had any advice on exercising with treatment, after treatment, but also on nutrition, any nutrition advice or support at all?
Yeah, indeed, there are definitely several initiatives if it's coming to rehabilitation or even pre-rehabilitation before we even start treatment to start already. So we made in cancer the major shift, like before we said like rest beforehand. We changed even to start moving and keep it moving and have exercise. And I saw the World Health Organization has a recommendations, but also after cancer, for example, in Belgium, we have in several hospitals rehabilitation programs, and now we're also moving into during treatment, like exercise during treatment. Currently, we're also running research on, for example, like individual prescriptions on exercise, because what we also see, for example, in cancer care is that if we're sending people back to home and they're going to the community physiotherapists, for example, they are a little bit like, oh no, because they don't have the education in particularly to cancer patients, and they are maybe a little bit afraid, like what we can do, like exercises, is it good, can we do it? So now we're working on a project that we're going to have like this dedicated, specialized, individualized prescriptions for patients. But I think exercise is real recommendation, and we should do more about it. And after treatment, also during treatment, patients should be referred to exercise, depending, of course, on the individual trajectory, what they can do. But also, for example, additional services like a nutrition. So in my service where we work, we have like a couple of oncodietitians, psychologists, physiotherapists, nurse consultant, clinical nurse specialists that all work around the patient to support also together with the physicians, the surgery, radiotherapy, to have like the whole trajectory, the support for patients. And now we're also building on survivorship trajectories. For example, one of our colleagues of the clinical nurse specialist is also, last year she set up like a law survivorship clinic so that people can go back and have the support and the information, what they can expect and how they can support, and looking together in a kind of shared decision making with the interdisciplinary team how to move forward in their life. Because like you said, there is a lot of things, and we can't ignore the fact that we need to inform our patients in what is coming and make the decisions together. So yes, so there is definitely a need to do more on exercise also. I think we have still for one question.
Yes,
time.
for one question.
I have a short comment, not a question, about the labor market and the employers. My perspective is quite different, and I have a feeling that I'm a cancer survivor. I had cancer, I finished my treatment 2 years ago, and I managed to change my job 2 months after finishing the treatment. I was bald. I had, my head wrapped with turban, and my employer didn't ask anything. I decided to tell my story at the very end of the whole interviewing process, and then they decided to hire me anyway. So I have a feeling that the world is changing. People in general are more and more aware. Employers are more aware. So remember that we have full right to come back to our real lives and to change whatever we want to change. That's my perspective. Thank you.
Thank you. Yeah, we have time for one more question, and then we will have to close our discussion.
Thank you very much. My name is Victor. I'm from Moldova. So my question is on the right to be forgotten, specifically on the mixed messaging surrounding cancer risks. So just to explain, on one hand, we have the anti-tobacco advocates often emphasize the deadly nature of cancer, highlighting the link between smoking and cancer mortality. And on the other hand, the advocates pushing for the right to be forgotten argue that many cancers are easily treatable, unlikely to recur, thus fighting discrimination against cancer survivors in areas like employment or financial rights. So these competing narratives can leave the public confused. What do you think about that, and what's the solution?
I did not, sorry, but I don't understand the question.
Yes, so I'll try to use other words. For example, there are advocates fighting tobacco, saying that if you get cancer, you will die. And there's advocates that fight for the right to be forgotten, saying that cancer is not a death sentence anymore. So it's not that bad. You should not discriminate us. You should include us into... So how do you see this mixed messaging in communication? What do you think should be the how should we better communicate in such areas?
But tobacco is an issue, and despite all what we are doing for the last 20 or 30 years, we cannot eradicate tobacco, which I think is a major mistake. Curing a patient with cancer is something achievable. I think eradicate tobacco seems unachievable. Because there are too much interest of member states in the tax, in the whole system, where they get back money from the selling of the tobacco, and so there is no real incentive from member states to eradicate tobacco. I used to say we should put the cost of the tobacco to 1,000 euro, but nobody does that.
Thank you.
Thank you for the questions. Johan, you mentioned that
Yes.
you have one more.
Because I have some provoking question maybe,
Okay.
and thank you, Dr. Ben O'Hara, to be online. But you were also talking about sexuality, because I want to break a little bit the taboo before we go to have a break. So what can we do as healthcare professionals? Because we know that, for example, young persons with cancer, also in the time that have like a lot of transition, but also maybe also developing their sexuality, starting a relationship. But if we as healthcare professionals don't talk about it, it's very difficult to open the discussion. So what do you recommend to the healthcare professionals to open that discussion on sexuality and intimacy?
So first of all, I have to say that when we talk about the physician visit, which is very limited, and we need to tackle down all those medical perspective, and usually this is something that would come up later on, sometimes during the follow-up time. I think that the best way to tackle it is to create these supportive programs. For example, in the Oncoyan program that we have a sexual specialist, and she actually is the address for us whenever we see that there is a problem with the patient. That first of all, we tell him or her that there is an address, that they can really come and talk to her. And sometimes what we do is actually have also some discussions in which she presents the topic, and then if they want, they would come in person and have a meet with her, and she can discuss with them. And we have a service for males, service for females. I think it's very, very important, especially for patients that receive radiation, because this is a part that we need to really inform the patients. Sometimes today, when we have also the possibilities to prefer another or to take another option, such as chemotherapy and perioperative chemotherapy and not radiation in rectal cancer upon to the prospect study. I think that this is something that should be discussed with the patient, because we cannot presume what is this perspective mean for them. So we need to discuss, and I have several patients that upon the discussion, they prefer to take the other alternative and not to receive radiation. Of course, if medically it's okay to, it's equivalent, and we can offer them the same alternative with the same possibility for cure, I think this is something that we should discuss with the patients. I fully agree with what the patient survivors on the panel mentioned. I think that we should inform the patient, we should have the discussion with them and not to just decide upon what we think, because everyone has his or her own things that they would like to take as their consideration and not ours. There are options today.
Okay, one more, and now we have to close. Can we have the microphone, please, on?
Can you hear me?
Yes, we
Hello,
can hear
thank
you.
you so much for having me here today. I just found out by accident about this conference yesterday. I'm in holiday, actually. And I am a cancer survivor. I was diagnosed in January 2022 with stage 4 liver mets. I had chemotherapy. I had double liver transplant. I had 1 year cancer-free, and now I'm fighting again because it reoccurred in my transplanted liver. I'm not sure if this question would fit here, but I would take the chance to ask if any of you knows about a similar case, a positive similar case of course, or if there are any feasible options for me, because I tried several second, third, fifth, sixth opinions, and people are scared to operate on a transplanted liver. So basically my question is there anyone else in my situation? Thank you.
I think that's a great question that you can ask during the coffee break. We have some clinicians here who I think will be able to help you out.
Thank you so much.
Thank you for listening to our panel and discussion. I would like to thank our experts, Dr. Heron, Dr. Munier, and Johan, of course. But I would like to express my thankfulness to our patients. Thank you for being brave enough to share your experience, to share some of the hardest moments of your life and turning into something that you can advocate for yourself and the patient that are going to come. And thank you for learning us a valuable lesson that we have to look beyond the treatment and look at the person that we are seeing in front of us. So thank you so much. Thank you.
We will now have a short break. It would be great if everyone could be back here in 15 minutes.
You show me, yeah. Am I on? Welcome back, everybody. I hope you all have had a nice coffee break. Can you hear me okay? It's good? Okay. We are going to get started with session 4. This is a session unlike the other sessions. There will be no PowerPoint presentations. It will be just all of us here having a discussion. And just a little insight into this particular session, I reached out to Dr. Travado and Dr. Lauro to kind of start planning the session, and it was very intentional that it stays an organic discussion where we involved the patients and we asked them, what is it that you want to speak about? What are topics that are of interest to you? How can we give you a platform to share your experience and talk about what your psychological and emotional needs and the support that you received and the support that you wish you had received, a way to share it on this platform. So with that, I will just be here to moderate a little bit, but it's entirely up to our audience here, our panelists here to guide where we go. And so I would like to introduce our psychologists here today. We have Dr. Lucia Travado, who is very well known across Europe for her work with IPOS and through her research at Champalimau here in Portugal, and Dr. André Lauro, who is an associated psychologist here through Europacol in Portugal, and he supports the local Portuguese patient community here. So welcome, both of you. And then I think it's important that the rest of our panelists introduce themselves and tell us a little bit about who they are and their journey through their diagnosis. So I think maybe we'll start with Patricia on the end there. Welcome, Patricia.
Should I use all my time now?
I think just give us an introduction to yourself, and then, as we converse, if there are other bits, go for it. Yeah.
Introduction, okay. So thank you so much, and hello everyone. It is always a huge honor to cooperate with DICE, and especially on the event like this, which is exceptional and amazing. Congratulations. I am Patrycja, as you may know already, because I was talking too much, because I am always talking. I'm a patient advocate from Poland, associated with DICE, Pancreatic Cancer Europe, and Europacol Poland. I am now 32 years old, and 7 years ago I was diagnosed with pancreatic cancer just 2 months before my 25th birthday. And to say that my diagnosis was a surprise is like a complete understatement. And I kind of divide my life into before and after cancer and this weird, very weird in the meantime period. And just before I dive into my experience a little bit, just a disclaimer, there is no taboo topic for me. I am an open book and I have no filter. Just this. So it was a sunny Wednesday in July 2017 when I went to see a second GP because the first one didn't believe me when I talked about the feeling that I had that something was wrong. I talked about my symptoms. And I also wanted to talk about losing weight, which we can say didn't happen at all since those seven years. And she referred me to have some more advanced blood tests and to ultrasound, which show some big mass in my abdomen. And 2 days later, the CT scan confirmed it was 16 centimeter tumor in the tail and body of my pancreas. And at that moment, my life just stopped. I like planning and organizing, just as a person, that's who I am. So all my plans went south in just a matter of minutes. I just finished my psychology studies. I was about to get my master's degree. I've had an internship plan, so my dream life was ahead of me, and suddenly I had to adapt to a completely new reality with additional tests, meeting with doctors, finding the best surgeon, while at the same time getting the dean's leave from university, sharing the news with my family and closest friends, and also trying to not lose my mind in the middle of that. And the mental well-being has always been very important to me, so I almost immediately found myself as a psycho-oncologist because I knew I wouldn't be able to go through this without professional support. And of course, as almost everyone, I'm a millennial, I Googled pancreatic cancer, and I saw all the information and statistics, and actually the perspective was not optimistic at all. And I am an organized person, as I mentioned, so in order to somehow survive this roller coaster, instead of having my plans and going my to-do list and all the things just to check and boxes. I had to try to be able to go in small steps and day by day, and that was a nightmare. I hate doing this. I love having strict plan and everything. And from diagnosis to surgery, 2 months passed, in which my psycho-oncologist has been a great help, talking to me and explaining a lot of stuff, teaching relaxation techniques, and also advising what to ask medics, some very practical stuff. For example, how long it all may take, what are possible scenarios, what would be needed after surgery, and the questions I wouldn't think of asking myself. And I'm a very task-oriented as well, so this kind of approach helped me get back the control over my life that I just lost to cancer, and it helped me also being very proactive in my treatment, almost to the point of being demanding sometimes, or even offensive. For example, when one of the surgeons told me that probably everything that is going on is because I was drinking too much alcohol, because I'm a student and that was a summertime, so of course I was partying like crazy. So I had the surgery in late September 2017. While tumor was removed, I had to stay in a hospital for 6 weeks because of the side effects, like the risk of sepsis and obstruction of pancreatic duct, which is still a problem. I have a stent there that has to be replaced, changed every 6 months. And those weeks were extremely hard. I was in a hospital far away from home, about 150 kilometers. One of my parents has always been there with me during the day, but then I was all alone at night, with just myself, and that solitude was absolutely terrifying. I knew I had my friends and my family in general, but in the end, I had this loneliness and this feeling that I am all alone with my thoughts, with my emotions, with my pain, and all of my worries. Additionally, in addition to that, I couldn't eat practically anything, so I started to lose also physical strength and needed help with some the easiest stuff, like going to the bathroom and changing pajamas. And actually, one of the hardest moments happened in the hospital when I had my first shower after the surgery. And when you are all super ill and dying, and you have this first shower, just super rejuvenating experience, and it wasn't unfortunately like that. So I took off my clothes in a bathroom. I looked in the mirror and I couldn't recognize myself. Of course, I was pale. I have under eye circles. And now I have a long scar from my sternum under my belly button. But back then, what I saw in the mirror was just long line of stitches with bruising and impurities. I saw actually a body of some ugly creature. I didn't see myself there. And honestly, I've never liked my body, and hell, I still don't like it. But in that moment, in this small hospital bathroom, I just broke down. And thankfully, I could count on my psycho-oncologist to discuss all the emotions that I've been feeling and all of the invasive thoughts that appeared. And also, in the meantime, I got the most important info and the most valuable information from my doctors that I was healing and I was going to be okay. So we were running up. So after those 6 weeks, I went home and I was slowly starting to a huge comeback to my life, old, new, however. Recovery, checkups with doctors, friends and family, my master thesis, and also new job, psycho-oncology, postgraduate studies, and the initial plan was to work with cancer patients, which now I do through all the advocacy and volunteer stuff I do besides my regular job. And about 2 years, that's not the end, of course, about 2 years after my pancreatic cancer diagnosis, it wasn't enough for me. I was diagnosed with depression and started psychotherapy. Cancer, of course, was a first subject to work on, and I think because I was physically okay, I was ready to face everything that happened to me and all the mental wounds and pain it actually caused me. It took me months to identify all the emotions and understand and deal with them, to see all the patterns in my thinking and behavior and to break them down and kind of build again. And to actually realize and understand what I went through for those 2 years and how much I've lost, time, health, and my plans, but also how much I've gained, which for me was strength, vulnerability, new plans, empathy, and even practical knowledge on Polish health system I've never had before. And also what's the most important, to realize how much I still have and how lucky and privileged I was in the whole my cancer journey with the support of my family and friends, including the financial ones when I just needed to get CT scan the next day, which is paying out of your pocket in Poland is hell of a money. So knowing all this, I was just realizing how lucky, actually, after those 2 years, I am, how lucky I am to just still walk and breathe and be able to be here.
And we're so happy you're
Thank you.
here, Patricia.
Thank
Thank
you.
you. Catel, would you be open to sharing your story?
So I'm Catel, I'm French, as you can hear, but I live in the Netherlands for the past 8 years already. I was diagnosed with stage 3 colorectal cancer at the age of 40 and had symptoms for several years, especially like fatigue and digestive issues. But my GP sent me home several times with paracetamol and asked me just to rest, telling me that I had a stressful job and I should travel less. And 1 year before my diagnosis, I started having red blood in my stool from time to time, but I was not too worried. I was treated for endometriosis, and the symptoms are very similar. And because I trusted my gynecologist, I saw that everything was under control. And at some point, I had red blood in my stools every day, and I started realizing that there was something wrong. But I was not too concerned. I'm a scientist, but I didn't know anything about cancer. I didn't want to Google it because I know that you can find the words online. My GP was still not concerned. I asked for a colonoscopy. She said, yes, if you want to, but okay, I'm going to prescribe you one. But I was on the waiting list because it was COVID time. So I had to wait several months. And I was booked for a surgery for endometriosis. And during the pre-op meeting with my gynecologist, I told her, I've got blood not once a day, but every time I go to the bathroom. And then she looked at me, and she was like, let's book you for a colonoscopy before the surgery. And I was like, I've been waiting for months, and nothing happened. She was like, okay, I'm going to give you a call. So she gave a call, and I got the colonoscopy within a week. And then when I woke up, then they asked me to wait, and I didn't know that it was not the usual thing. And then the doctor told us, because I was thankfully with my partner, and told us that it was cancer. Then it was such a shock for me because I didn't have any idea, I didn't know what cancer was. They didn't tell us more. They were just like, okay, you're going to be a VIP, you're going to be on a red, you're going to have a nurse to help you to book all your appointments, and everything is going to be organized for you. So I got everything organized within 10 days. And I think those 10 days have been the worst of my life, waiting. I knew there was something wrong, there was cancer, but I was still hoping that it would be a stage 1 because I didn't smoke, didn't drink at all, I was exercising. I felt rather good. And the way I learned that it was cancer is that before my official debrief with the surgeon, I had a call from my gynecologist telling me that she was so sorry that she had to cancel the surgery because of the cancer. And she didn't know that I didn't know. So that was a bit of a confusing moment for both of us. And so that's the way I learned that I had cancer, officially. And then the following day, when I had the first appointment with my surgeon, that's where I realized that it was far more than just cancer. It was a stage 3. It was already quite far advanced, really close to a stage 4. There were some lymph nodes involvement, and the tumor was badly located. If a tumor can be well located, I don't know, but the surgery was extremely difficult. And the first question I had was, do you want a permanent or a temporary stoma? I was like, I don't want a stoma at all. I was like, okay, you're going to have an appointment next week with a stoma nurse. And I was like, oh, wow. And that was the first thing. And we discussed very briefly about fertility preservation. I was 40. We wanted children, which was not possible with endometriosis, so that's why I had the surgery. And in my case, so the ovary transposition was presented to me, but it was clear it was not an option because I would put my life at risk. So there was the option, which was not a real one, but it was presented. But it was basically between trying to save one ovary or my life. So I decided to save my life. So I went for chemotherapy and radiotherapy for 5 weeks, which worked very well. What we saw was a complete response. So I had the proposition to integrate the wait-and-see protocol. And at that time, I think they didn't have enough data on young patients. So that's where I realized that with my scientific background, I could really look at data and look also in scientific publication and try to understand if there would be something for me, if I was willing to take the risks, because there are still risks. So I had still my surgery booked for the 14th of July, and the day before, so I had all the pre-op appointments, and at last-minute MRI to really see if I could be a candidate for that protocol. And then we decided that, yes, I would give it a try. It's psychologically very difficult because it means that every 3 months you need to go through MRI, scan, colonoscopy, and blood test. It's super heavy. It's 10 days of tests, then the waiting. So you've got 2 weeks of extreme stress, which was, of course, not the best. At the 9 months follow-up, they told me, you're good, just restart your life. So what I did, I started my own company, decided that I wanted to study psychology, register for the university in Amsterdam. And then on the 1-year follow-up, they told me, okay, the tumor is back, so you need a surgery. And back to the question, first question, do you want a permanent or a temporary stoma? That's such a difficult question because they don't have any idea of how severe LARS could be. And you heard the story about LASMA this morning. They don't know, and I didn't know anything. And my tumor was extremely low. I had radiotherapy, so I was at higher risk. But I was still young, so we were like, okay, if it's possible, please give it a try for a temporary stoma. So I woke up without knowing what was done, so which was also extremely difficult. So I had a temporary stoma, which I saw was good. At the reversal 3 months later, and then the worst time of my life started. When everybody was happy for me, I was supposed to have my life back. I was cancer-free, of course, so everybody was, oh, but you're good. And I didn't leave home for 6 weeks. My life was miserable. I didn't have any quality of life. And I was like, yeah, why did I go that way? And then they were like, no, but you need to wait. It can improve up to 1 year. And I was like, 1 year? That's very long when you cannot leave home and when your way of coping is exercising and when it's exploring outdoors, which was, of course, extremely difficult. I had several complications, some other surgeries, and after 1 year, I was in constant discussion with my surgeon, and at some point he was really like, maybe we should think again about a permanent colostomy. And I was not ready at that time, and I'm so thankful to him. He let me the time to get ready for it. I say we chose to go for a colostomy. It means that he was there, and I was also part of the decision, and I took the decision. It took me several months, but I went for a colostomy. It was last December, and had some severe complication after the surgery, so I spent more than 3 weeks in hospital. I spent New Year's Eve in hospital, which was not the best time, because we didn't want to let anyone know that I was in hospital, so on the 1st of January, I received all the message, hey, Happy New Year! And I was like, it's not the best start. And then we didn't know what was going on. I was in a lot of pain. They couldn't see what was going on. At some point, one senior surgeon came to me and was like, don't you think it's your anxiety? I was like, could be that I'm anxious because there is no way back. I've got a permanent colostomy. There is no plan B. My life is in danger. Yeah, I don't know what to do. And then finally they found out that my colon was dying. So there was really something. So I was planned for an emergency surgery 2 weeks later, but I didn't make it to the 2 weeks. So I had to be hospitalized 2 days after that decision. And one young surgeon decided that it was Friday afternoon, that he had one spot left in the theater, that he was going to do the surgery. And I was like, I didn't give my consent. And I was alone because I sent my partner for lunch because he was starving. and had the two nurses from the theater asking me the questions to fill the questionnaire before the theater, had the doctor from the ER, and I didn't know what was happening. I was like, I'm not going for surgery. They were like, yes, but that's the only spot before the weekend, and you don't know what's going to happen during the weekend. We might not have another spot available, and you know that you need surgery. And I was like, yeah, I know I need surgery, but I need it to have it planned, and with my team, with my surgeon, and it was like 5 minutes where I had 4 people next to my bed trying to convince me that the surgery was the best option for me. And I said, no, I won't go. And I think I was 3 years through my journey, and if that would have happened at the beginning, I would say, yes, I go for surgery. Yeah, you know what you are doing. But at that time, I felt confident enough that I could say no, and that was the best option for me to do it with a surgeon, because it was my 7th surgery in 2.5 years. And my surgeon knows me better than anyone else, know what happened and what he did. And at the end, I'm so glad I did it. I had the surgery a few days later, and it didn't go as planned because it was much more complex. And he told me, yes, I'm glad I did it because that was complex. If I would not have been a patient advocate, I would have never said no, and I don't know what would have happened. And I think that was also a lesson for the young surgeon to realize that it's not because the theater is free that you need to go for surgery. And I've already talked quite a lot.
That's okay. Thank you for sharing that. It's really important that you highlight what you learned throughout your journey, and you felt strong enough and empowered enough to speak up for yourself.
And I think that also at the time where I was diagnosed also with PTSD, I realized that I had some support, but from a social worker, and I realized that there was not enough. That also, especially when I was in hospital for those 3 weeks, I had really some moments where I had some kind of panic attack, which for some invasive procedures, which were painful but not too extreme, and I didn't realize why I was so much in panic. And it took me 1 year to start psychotherapy because there's 1 year of waiting time, which is, I mean, you know you need it, you know that you are diagnosed with PTSD, but they cannot do anything because there is 1 year of waiting time. And I would have needed it so much during that time. But I'm so glad that I started it in May, and I did 5 months of sessions, and I'm now at the final session 1 month ago, and I feel so much better. And I don't really understand why, in such a complicated case, why it was not provided to me before, because there's such a need of support when you go through such a long journey. I mean, getting diagnosed with cancer when you are so young is, of course, like you say, it's such a shock. I mean, it's not even a word. And I think as young patients who are not even prepared for that, I think that should be mandatory.
Support, yes, absolutely. Let's include that in the discussion when we get there. And now maybe Natalia and then Alex can share. Thank you for sharing.
Thank you. Good morning, everyone. My name is Natalia. I'm very grateful to be here today to share my story, so thank you for listening. I'm originally from Colombia, but with my husband Alex and our little dog Bali, we live in London. Almost 4 years ago, in January 2021, my life changed completely when I was diagnosed with stage 4 gastric cancer at the age of 33. I had always been healthy diet, exercise, known smoker. I didn't have any family history of gastric cancer, so this diagnosis came completely out of the blue, and we were in shock, and it really felt like a life sentence at that time. For me, the symptoms started with a cough, and it's funny because it was the middle of the pandemic, and the cough was the worst thing you could possibly have. So I was trying to hide my cough everywhere so that people won't think that I had COVID. And I remember going to the doctor and talking about my cough, and they would do just a COVID test and say, oh, you're fine, it's not COVID. Don't worry, go back home. And again for several months until after a conversation with my dad, he was very strong, telling me, you need to get further examinations. This is not normal. The cough converted into a pain in the ribs and then a pain in the back. Huge pain. I had to stop running, but then in 2 months later, I could barely walk. So it was going extremely aggressively. And I had to really negotiate and have a very heated conversation with my GP in order to get a CT scan. After months of examinations, my diagnosis was confirmed, and then all the treatments started. So since then, I've undergone a range of treatments, including chemotherapy, radiotherapy, and surgery. 3 years ago, after the chemotherapy, 8 cycles of cisplatin, the cancer returned, despite just having finished the chemotherapy. I was feeling much better, but there was a little bit of cancer returning. And at that time, I had 2 options, either going for more chemotherapy, or there was a potential of joining a clinical trial, phase 1, at the Institut Gustave Roussy in France, in Paris. So it was clear to me that if there is another option and it will avoid me more chemotherapy, I would go for that. But getting into a clinical trial is not easy. So all the planets need to align and all the tests and everything, and we were very lucky that it happened like that. And I got into this trial 3 years ago. The trial involved, it's a targeted therapy for a MET inhibitor. And I immediately started responding extremely well. So since then, I did have a few complications at the beginning with a second primary on the skin, which was easily removed, thankfully. But since then, I had no evidence of disease, and one could say that I'm on remission for the last 3 years. But the journey with the trial hasn't been easy. Apart from the side effects, there is a lot of mental anxiety and a lot of physical as well, work, because we need to, living in London, travel to Paris every week at the beginning, every 2 weeks, and now every month to get the treatment, and the mental anxiety of being on a phase 1 clinical trial that could literally go very well, but it could literally also go very bad. It's very difficult to manage. I was actually thinking about it and thinking about this conversation in mental health, just realizing that actually never during this period I was asked or proposed to have a mental counselor as part of the trial team. And this is, the hardest part with the trial was a year ago when we were informed that the trial was going to shut down, and I was told that the drug that was saving my life would no longer be available to me from next month onwards. We were completely shocked. The team in Paris was completely shocked. This was a decision made by the pharmaceutical company in the US, and after months and months of going back and forth, and actually this is the reason why I got in touch with Dice and Natasha to help me advocate for myself. And after advocating for myself through Dice, through the hospital, we were able to reverse the decision of the pharmaceutical company, and I continue still to receive the medication. But we don't know for how long. I can still receive it. So basically they said, you can receive it for as long as we have stock. So this is something that causes a lot of anxiety as well. And we need to think about a plan B. And I think it just highlighted how vulnerable patients are navigating those clinical trials, and how, if you don't have a background in in pharma or in this world, it's really hard to know who to speak to and how important the work that does is. So through all of this, what I've learned is that cancer, yes, it is a physical illness with very clear physical challenges, but it's also a battle in the mind. And a lot of this journey is mental and emotional. So I don't believe that today young patients are receiving enough support to navigate these challenges, because it's a long-term challenge. It's not just the diagnosis. Yes, you go through the diagnosis, you accept it, you move on, but then the treatment happens, then you need to survive. And the care is just not there continuously. I also feel that when you're diagnosed at a young age, every part of your life changes completely. It's what we've been discussing in this conference. But you have to stop working. The finances get affected. Fertility is affected. The daily routine, even sense of identity is so complex, so complex. There is a whole process of grieving the life you had that you need to go through, and this is a long process. So the good news is, well, I've been able to find and navigate these mental challenges, and for me it's all about building a toolkit that has helped me manage this and taking it day by day. So in my toolkit, obviously, therapy has been paramount, and it has really helped me a lot. And being constant with that, but also meditation became a way for me to calm my mind and be present. I see incredible benefits from meditating when I'm constant. Exercise as well, as we discussed earlier. I do yoga, but I also do exercise. So all of these are things that are helping me cope with the mental anxiety. And then finally, I'm also a huge believer on the healing power of food. So nutrition is also part of my toolbox and something that I study and I'm really interested in. So when difficult moments come, and they will continue coming because this is the journey, I remind myself about returning to these basics and this toolbox. And obviously, leaning on my community as well has been incredible. So my husband, my family, my friends, they are constant sources of inspiration and support. And I think the most effective medicine. Thank you.
Thank you, Natalia. As Natalia described, Alex is her partner, and we have the very unique opportunity to have his side of the story, which is not easy. So thank you, Alex, for being open to being here and to sharing with us.
Thank you for inviting me. So I'm not a patient, I'm Natalia's husband, and I will share with you some highlights of my journey as a caregiver. So first, when Natalia got sick, I must admit that I was in denial. I was telling myself, it's not as bad as it looks, we'll return to normal soon, it's just a matter of rest and recovery. But as the reality unfolded, it felt like watching a disaster in slow motion. Little by little, scan after ultrasound after surgery, the good outcomes, the non-cancer ones, were crossed out. I simply didn't want to believe it. Have the doctors missed something? What if they are all wrong? What about that study that shows the same scanner results and the same symptom that is nothing to do with cancer? But anyway, doctors needed to hurry because day after day, the pain of my wife's life was more painful. She was less and less able to walk, and that's feeling to see the love of your life going such a dramatic journey without a cure, because we couldn't start chemo before we knew what was happening. It's a feeling absolutely horrible, helplessness. And that's also the role of a carer here, of a caregiver, is to make sure that there is no stone left unturned, that doctors don't have any blind spots. Doctors at night, they have another life. Patient will take some time in their mind, but at the end of the days, they have their own life they have to go on to. For caregiver, it's 24/7. It's your whole life, not your whole life, but it's your love of your life, which is at stake. So we have to make sure to be ready for the future, to make sure that all scans are clear and are sorted. We need to make sure that that there is no stone left unturned, no medical blind spot here. Of course, I had to take time off work just to process what was going on, and to be with Natalia, as it could have been her last moment. And to be honest, my mind wasn't able to focus on anything else. I was lucky to have a supportive boss, but I had eventually to go back to work because we had bills to pay. And actually, it's a trade-off. As a caregiver, I'm not on any kind of medical leave. Caring for someone requires time and requires mental energy, and so does work. But work gives money, and in the UK where we live, gives medical insurance. So it's a trade-off here. It's a very difficult one. That's why getting the proper support at work is absolutely essential for a caregiver, because we need to be able to attend medical appointments, to be able to take last-minute leaves when something goes wrong. These are not luxuries, they are necessities. Just as there are parental days and sick days, there should be also caregiving days. I haven't mentioned yet a hidden cost. I found that in this new life role of caregiver, it changed my relationship with risk. I became more cautious, more inclined to stay within my comfort zone. Why would I venture into something new? What if the next crisis came and I wasn't prepared? The mindset is very difficult to shake away because it's ingrained for survival, it's rooted in survival. So back to our story. When my life was diagnosed, it was in the middle of COVID, and we were extremely lucky that my in-laws could get visas and travel halfway around the world despite the ongoing restrictions here. And what I want to say, family and friends, support is essential. My in-laws stayed for 6 months. It was absolutely a blessing. It gave me time to recharge, time to do something else, time taken off duty here, if I may say that. In challenging time, caregiver burnout is a real thing. I will say we don't have kids. We are lucky here in that meaning, in that sense. I can't really imagine what parents go through. I'm also lucky to live in a country where talking therapy is widely available and affordable. Talking to someone confidentially, sharing private thoughts without worrying to be a burden or even to be judged made a big difference. You can't do the same with friends and family. Finally, self-care has been a crucial part of my journey. Here I'm talking about meditation and mindfulness, staying active, these are lifelines. Because remember, if we're lucky, it's about being a caregiver for the long term. Thank you.
Wow. That was incredibly brave of you, Alex. Thank you so much for sharing. I'd like to now introduce Lucia to maybe give some of her insights and then have Andre share a bit of...
Sure. It was a good decision not to have slides here because what they have told us and shared with us is so powerful because they are experts in their own experience. And so we should hear them more and more to see that cancer treatment is a humanistic. We are not talking about objects, probably neither patients, but persons that have cancer. And so the journey is so overwhelming. I think the word that we can use here is overwhelming. So it is time that we put essential requirements for quality cancer care that are written into place, which means that psychosocial care needs to be there from the first moment. That's why it's something that ministries of health need to put on working the resources, because it's their own recommendations, the evidence is there that facilitating this journey with a proper psychological support makes a difference, even not only for the quality of life and well-being during the journey, but now we have the evidence that it also impacts patients' clinical outcomes. Those patients who do better can resolve the depression, can learn to deal with their anxiety by proper psycho-oncological care, they will have better survival, because we now have also psychological interventions that have proven that way, not only to reduce the distress, the anxiety, the depression, but also because the patients feel better, they have less inflammation, less dysregulation and cortisol and so on, that we now know that influences how the cancer may progress. So it's not about, it's not a luxury anymore to have psychological support like everyone has mentioned, but it's part of the essential ways of providing quality cancer care to patients. We now have all the technology from the surgeon's part, the medical oncologist, the radiation oncologist, the immunotherapy, the target therapies. Things are getting a lot better, but psychosocial care has been always under the carpet because it's a silent suffering. Well, silent if you don't speak it, and if no one is hearing. But it's really something that patients have not been so much allowed to disclose to their medical doctors, mostly because they are already so thankful for saving their lives, that they think, well, I should suffer on my own. But that's not the solution. The solution, as we've heard, this is a long journey. And so patients need to be helped to be prepared to foster their own resources and mechanisms. Some they can learn, like mindfulness, which is very helpful. They need to know how to decrease the catastrophe ways of thinking, like you've mentioned. It's normal for patients when they have a diagnosis to feel that there is this, how to say it different, death sentence, so to speak, that their life will be shorter or at least impaired, that I'm not going to be able to do my plans. And this is quite difficult. And so this needs to be addressed. This is like a big stone falling on your life. And then you have to build resilience and coping modes to go across. If I have this stopped, how can I go the other way around? And it's not because we heard there is such a burden. Symptoms, there are already symptoms. The treatments are quite aggressive. They produce also side effects. And how am I going to deal with my emotions if I don't have support on this? Patients feel, and you use the word helpless and hopeless. And that's one of the things that we help patients focus in. What are my solutions for my case? What is my hopes? What can I believe on to carry me on? So it's really important that we help patients focus on this. And that's why all of us are part of the treatment. Caregivers have a tremendous also hassle, because you've said it's a 24 hours per 24 per 7 days a week. So you are also part of the team, because you are our co-therapists at home. We are our supporters. So you need also to be aligned with the team. What is the target? What are our hopes, the hopes of the professionals? What are we looking for? How can we go through this? And of course, someone mentioned, patients need to be involved in decisions. Why not? Everyone is in control of their own lives, and they don't want to lose control. So they just need to learn about the disease, about what can be done, so as to regulate expectations and to place my own focus and all my mental energy on what I can do in spite of what I cannot do. And sometimes when we're talking about a disease like digestive disease, which has a very, very bad reputation so far, it's becoming better, but there is this bad reputation. And many times patients suffer from the bad reputation and focus on that instead of focusing on the hopes. But it's not their problem, it's that they need to learn how to do that. And we, the psychologists, are the ones that are prepared to discuss with them what they can do to foster those competencies that I'm sure all of them have. It's just that being overwhelmed, you cannot see the horizon. And so it's one of our quests, it's to help patients to take the stones away and to help them see the horizon again. And all of us, medical doctors, nurses, psychologists, physiotherapists, nutritionists, exercise training persons, all of us are part of the team. And that's how we do whole person care. And I hope that, being this a European project, that there will be some actions out of this conference to place more emphasis on what are still the gaps in the journey of the patients, and how we can put more resources on hospitals to take care of patients, and also look for carers and include them. I have to say something which is not very nice, which is because our area has not any pharma on our behind, it has been overlooked. So we now have to put more emphasis. We don't ask for much money. Our profession is it's not being so expensive compared to very fancy drugs, but it requires the national government to put resources into place that ultimately help patients to go back to their normal life and be more involved again, happier citizens. So that's what we have all to work together, like Johan was saying, joining forces and working together to put these essential requirements for treating the whole person, not just the cancer, but the whole person in place. So thank you, Entero and Digestive Cancer, for putting this conference so that we can really and openly discuss all these issues to help governments and Europe in putting the right emphasis on what still needs to be placed. So, thank you.
Thank you, Lucia. I think that's a very important call to action and something I hope that we can have the privilege to work together along with our community of young individuals. Thank you. Dr. Laura?
I would like to talk about my experience with the patients and the caregivers. So one of the things that normally I work is what normally the patients know about the disease. So the idea, if they don't know what happens with them, probably they know how to cope better. So first of all, normally I try to, with the patients, try to know what they know about his or her disease. So the idea is to have a good communication with medical staff. Because many of the problems, in my experience, there's a lot of problems when the patient, they don't know what happens with them, and they don't know what they have. And the problem is to manage with the doubts. So the idea, if they don't know, they have to know. So they have to have proactive, to ask to the doctor what they have and what kinds of treatments they have, what kind of side effects of treatment. So they have to know what they have, first of all. So the communication is very important. And the reason for that normally we work with the perspective. So if I have the wrong perspective of my disease, probably I will have a different resources. So if I have a harm perspective or danger perspective, probably my distress will probably I will have more distress. So first of all, I try to see what kind of perspective that they have from disease. Because if I have a good perspective, probably I will have the challenge. And if I have the challenge, I have a better way to cope with disease. I have more strategies, okay? But I have to have the realistic perspective of disease. Another thing that, in my opinion, is important, of course, when I have my appointment, one thing that is important is to express my emotion. We call it ventilation of the feelings. Because if we put all the information and if we talk about them, we are going to restrict our way of thinking. So sometimes we are like a mirror. We are like a mirror, and then, so I'm trying to explain how we work. And then another thing that we work like behavior techniques that we already talked about, the relation, mindfulness, sense of control, active scheduling, okay? But we have cognitive techniques too. For example, we try to help the patients to identify negative thoughts. Sometimes I have, of course, negative thoughts, but it has to be realistic, not pessimist, not optimistic, okay? And sometimes the idea, if I have all the information about what happens to me, I'm not going to create a speculation of thinking. Okay? That is not to speculate, because it's just only thinkings. Okay? So what we work to is to have a realistic thought, and then what kind of resources that I can to have to manage this kind of thoughts. Okay? Because many of problems that I have, anxious and distress and depression, is when I have negative thoughts that always in speculation. I don't have, these kind of thoughts are not realistic. So I'm giving some ideas, then now we can discuss about this. So the idea is, first of all, what was the relationship with the medical staff, first of all, okay? Secondly, what kind of resources that I have to manage the disease that I have, and if sometimes, and that is very important, is to think in a moment present. It's very difficult, because our head is always thinking ahead, but we don't know the future. And sometimes when when I am with my patient, I say, so you are sometimes the patient, okay, maybe I'm going to have this and this, and I ask, but how do you know? What kind of information that you have for this? Okay, and we call it futurologists. Think always in the future, and of course, what brings distress to manage the things. So the idea is to think in the present, and always my thoughts will be on the facts that I have. Okay? So I think now we can discuss about that.
Sure. When Catel was explaining about her situation, she talked about the things she does now that brings her joy. Maybe that's something you would like to lighten up the mood with, a more optimistic outlook of how you cope by doing the things that you love, the things that bring you joy and excitement. And
yes, there are many things, I think, and a few things really helped me this year, because I had my surgery in January, and that was not planned. And I had my year at 24 planned as recovery and enjoying. And then the emergency surgery kind of messed up everything. But I had a few travel plans, and it was super important for me to go. I have to say my first trip was to London. That was 5.5 weeks after my surgery. My surgeon allowed me to go, I want to say. I was not supposed to leave anything, but I could manage it. And for me, that was scary to go alone. But my partner told me, if anything happened, I can get you back. And that helped me a lot, give me the security that if something would happen, I was not alone. So that was in March, and 2 weeks ago, I went alone to California, 11-hour flight, and I didn't have enough stress. I'm confident, I know that I can handle everything, and that gave me so much joy and power. I got the freedom to do what I like again, and with my partner, we both love outdoors, and with Lars, being outdoors is mission impossible. But with a stoma, it is. And we went hiking, and that's what we both love. And I think that helped us also to recreate the connection between us, because he was my caregiver for almost 4 years. And the difficult part also when you are a caregiver and a patient is how to balance it and be a couple again. And we went through a lot because we wanted a family, we wanted a child. We've got a cat. And we had to redefine what is a family. And we had some help also with a social worker too. We were good with the family, with the two of us. And we've got so much more freedom without kids. I know that it's also not something that people are ready to hear, because people say, like, oh, why don't you adopt? We are fine without kids. We live our best life at the moment. So I think that's really, and just to give you an example, so not everything went as planned in the US. So we were in the middle of the Yosemite Park, amazing, beautiful, but of course no bathroom available. And I needed to change my stomach bag because the American food didn't go so well with my digestion, even if I was extremely careful. And we made it as a joke because there are bears there, and they were like, is there a bear watching us? And then it's kind of a joke, like, yeah, I can change my my stomach bag in the middle of Yosemite. And when we, in the flight home, I didn't go so well also with the food, and I needed to change my bag when they were serving food where there was no access to the bathroom, and it was kind of panic mode. I was alone. I was like, what should I do? And I was like, yeah, if I can change my bag in the middle of Yosemite, I can do it in a plane. And I just asked the stewardess to have access to the bathroom. Everything was done, and in 5 minutes, everything was under control. And I think that gave me so much more freedom and independence. I can do things. And one last thing that I would like to add is I heard so many things about having a stoma, the limitation of having a stoma. I went kite surfing 1 month ago. Yeah, and I think that's where, I think for me it's really super important to raise awareness and to be open about having a stoma with everything that I do, because it shows that also with patients with LARS, with a severe LARS, that there is an option. It's an option for them. It's not an easy decision, but you can have such a much better quality of life, and you can exercise, you can be outdoors without having any issues. And that's sometimes not an option that is proposed because, of course, a stoma is not so well perceived. And yeah, I think we really need to change that.
Do you feel like you have this confidence to change your stomach bag in front of a bear, or kite surf, or travel all the way to California because you've taken care of your emotional well-being now? Do you feel like you would have had this confidence before you embarked on that journey of healing yourself, or working towards healing yourself emotionally?
No, I think the psychological support was essential because I was re-traumatized by the treatments. Yeah. I was traumatized. Also, I realized that all my traumas happened when I was alone during a procedure, that my partner was not there. So I think in my mind, also being alone was associated with a lot more anxiety. And I think the therapy helped me to realize that I can do much more. I don't need my partner to be always with me, but we needed to recreate that space also between us and to change who we were. That I needed to get independent again. He needed to give me the space, and that was a long process. It didn't happen in one night or one day, and I'm really so thankful for everything that he did, like also letting me go. But it's a long process, and very often partners are not included in the psychological support. And I think that's really the missing part. We did a few sessions together, and that was so helpful because for the first time it was a lot to open up. And I think as a caregiver, you don't want to tell your partner how you feel, how much you fear, how much you love your partner, because it's also difficult words to say. And I think being held by a professional, just to have this safe space to express your feelings, it's beautiful, I think.
Mm-hmm.
Alex, would you like to?
I just want to pick out what Andrea was saying, because he was addressing that in our comfort zone of the consulting room, our patients can open up their Pandora box with all the demons, fears, and frightens. which they try not to place on their caregivers. So it's really helpful that they discuss these, what Andrea was mentioning, irrational thoughts, because of course they have fears that are, they have thoughts that are normal, but they have catastrophic thoughts. Like when you were saying, Natalia was saying that when I received the diagnosis of cancer, I felt it like a death sentence, but that's something that people cannot avoid. They just have to be helped to process that thought as an extreme negative thought, but then we have to bring the reality. What has the doctor told you? Oh, he has offered a solution. Okay, so let's focus on the solution. It seems that your problem has a solution. And of course, so we have to move our patients from the impossible, this is going to be the end, to no, this is going to be the beginning of a journey that you will have a team to help you deal with. And the psychological support makes it easier for the patient, easier for the carers, and easier for the team. The doctors sometimes do not realize that a patient becomes much less, demanding if they are okay and they understand the process. And so that's why it's so important that all of us are part of it, including the caregiver. As Andre was saying, it's so important. The caregiver comes for the consultation, but sometimes they don't come for the psychological consultation. But I usually invite them, because I know that they are my co-therapists at home. If I'm helping my patients to be more realistic and hopeful and to focus on the solution, but if the caregiver is not on the same focus and is depressed, that is not helpful. So I need them both to be aligned with the target that the team has for the patient, that the patient has decided, and that we are all in this focus and in agreement and working for it. So it really makes a difference to have every element engaged, has to facilitate and ease up a process that is really, really extremely challenge, as we heard the testimonies here, and I'm so thankful that you shared with us. Your experiences, as you place them, are textbooks for all of us healthcare professionals. So thank you again for having this closed, because I know it's very demanding on your own emotions. But yes, that's the reality that all of us need to understand. And another thing, just to say, it's so important to give time to patients to process and not to have to decide on that consultation, on that particular moment. Your life is going upside down and you are trying to hold control over it. So you need to understand. You need to understand what's going on. What can I control? And the decisions is some part of what you can control. And the compliance upon the treatments that your doctors are going to suggest you is so important. But the compliance only comes if you have been involved on the pros and cons of the different possible solutions. Because the consequences are the ones that you have to live with. So you have to be able to choose those and say, okay, I see that the scenario, it's not so great, but I prefer this solution over this solution because I prefer to handle these consequences over those consequences. So it's up really to the patient to do that decision, and for us healthcare professionals to allow patients to keep control of their own lives. I say that we do not decide for patients' lives. We only counsel them what can be done. What are the solutions? The patient should decide. And if everything works like that, maybe it's better. I don't know. You will have the saying over that.
Patricia, did you want to add something to that?
Not putting me in the spotlight.
Patricia, you can say what was most helpful from and what was less helpful, what should we aim for, these kind of things.
It's it's always like super interesting also from my perspective to like engage with other patients, because we can have like a cancer, this is something that connects us, but then all of our like we are like individuals, and our experiences are so different, and also like because who we are as a people, and I've always had like a huge support group from my family. We are super close. We have our coping mechanism is dark humor, so which may seem like even to the like darkest dark, which was like I saw it in other patients that they were like, whoa, slow down, like where are you going? And like for example, my cousin was like, you cannot like die right now. What I'm going to put in your grave? You don't even have your master's degree. Like, what the hell? Like, don't be a disgrace to the family. Like, and my mom was like, okay, I know, I've always knew you are special, okay, but stop, okay? Like 25 years in pancreatic cancer is too much even for me. So that's like, there are like different like techniques to actually fight with everything. And I think like, I would love, of course, every patient to have this kind of mental support during, I think it is super needed and super helpful. I, for example, had to pay it from my own pocket because it is not like maybe it is now, but 7 years ago, it was not a standard in Polish health system to have some additional, some mental support. And also what I saw is like, in hospitals, the most important is you are physically okay. Thank you, go by and good riddance, have a nice life. And you are like, whoa. Like, first of all, I was like in some kind of system, and I had this sense of belonging somewhere and like having a purpose, some kind of routine in a hospital, doing this and this at this hour, meeting the same people. And now, okay, now I'm coming back to my life, which is great. I love being at home. I love my friends and I love my family, but I am not the same person I was a few weeks ago. But I am in the same place, and everyone kind of expects me to now be okay because I am like physically okay. And it's like kind of this dichotomy, because everyone is like, even if you meet like your friends on a street, someone you met in high school, it's like in a small cities, everyone knows what's going on. And someone is like, hey, how are you doing? And I'm like, do you really want to know? Or is it just a pleasant conversation? Because like I can tell you how I'm doing, but are you ready to like cope with this? And also, I've always been super open about my emotions and always been like very like conscious about stuff and aware. Also, probably because I am a psychologist, so it was a little better for me. So I'm not the easiest one to discuss, to talk to sometimes about this stuff. So I think like, and also I had this kind of hero complex. I've always been the funny one in my family as well. So I always tried to make everyone feel included, comfortable, happy, and everything. So even laying in this bed, like feeling like a total monster and like the worst person ever, I was trying to like bring everyone up and being like, no worries, I'm okay, I'm doing great, everything is fine, I will just have a face mask, I will just, maybe call my cousin for a gossips. And then my mom was leaving hospital because it was time to leave hospital, and I was like, shit. Like, would they actually see if I just go and kill myself because I cannot handle this anymore? So kind of this, being like a super funny and kind of happy-go-lucky because you don't want other people to care even more about you that they do. And, they also like sacrifice their time. My mom had to take a few weeks of work just to be with me in a hospital, and everyone is just, messaging, like, how are you doing, and calling you, like your closest friends and family. And I just had this feeling like I was taking so much of their attention and of their love and the support that I couldn't like I couldn't take anymore. I am much more of a giver than a taker, so I couldn't stand myself like taking. So like a huge part of my therapy was to like letting people take care of you, because if someone like your family or your friend is bad, you are just calling, going, helping, and that's like super normal. But if it's you in this position, you are not that able to be like, yes, I need a help, I need a hug, I need you to come over and I don't know, make me a dinner or bring some groceries. So there are like those issues I think we have, and this is like only my experience. I can just go on and on, like a lot of stuff happening, and for all of us patients, we are like individuals, like the statistic of one, like my friend like Ali likes to say, she's the statistic of one. So we all have our individual experience, and we all go through this range of emotions and different mechanisms and invasive thoughts, and in the end it's like sometimes we're like, can I be happy now? Like, is it even okay to be happy? And like, I saw my mom being like super sad, and my dad caring for mom so much, and he thought I was okay. So he was like, just try not to cry in from your mom because she's already like super worried. Like, thanks. Like, I'm trying to cope with my emotions, and yeah, let's also care about my mom. Like, I don't want it to be, a jackass to my mom or to my dad, but I still wanted to like cry and get a hug from my mom, or yeah. So there's like the range is like this, and the worst thing is that in a doctor's office, the most important is that you are just physically okay, and that's all. Like there is no like, maybe not everywhere, but in Poland, unless it's like there is no talking about mental support. It's like why you are worrying? You are okay. Just go ahead. And it's like, yeah, I'm 25, I'm 30, my life has changed. I should not do this. I don't know what will happen in a few years, but yeah, just go and enjoy your life. Thank you for nothing. So yeah, like I think this is like, there's no unique, every experience is unique, and there is no like the one like regulations or the protocol. I think how patients can be helped, and sorry for taking so much time.
No, don't.
Because
don't
I can stop
no,
myself.
I think it's really...
It's your fault. You asked me a question.
I think you said it really well, that, despite having access to this mental support in Poland, you seem to have found a way to manage and cope and find the support that you need. So I think that's really, really remarkable. And then I just wanted to come back to Natalia. You mentioned that you have developed a support toolbox that helps you. Maybe you can speak about that to inspire others as a way to navigate what they're going through.
Yes, of course. I think for me, in my process, one of the biggest aha moments that I had was understanding that health goes beyond just physical health, and that it is multidimensional. So physical health, extremely important, of course, but mental health, spiritual health, and emotional health. So how can I think about health in that way, and how can I have a tool that will help me physically, obviously, my medical team, but also nutrition. And mentally, I have my mindfulness and meditation, and spiritually, I do my yoga. And there's so many other angles and dimensions that when you actually start looking at it that way, you feel, one, more empowered, and two, more balanced. So it stops being only about the tumor and of course you need to do that's extremely important, but there's other things that will help you cope. So for me, it's looking at it that way, and I think understanding that I also need to have a mentor or a team around those areas. So I speak to my nutritionist a lot, and I speak to my meditation teacher a lot, and my therapist, and it's not only my medical doctor oncologist that needs to answer all the questions, because they don't know everything about everything. So it's all about creating that team very intentionally, and kind of around, building that toolbox that when you need it, you can go back to that.
And do you have a shared toolbox that you guys use for your relationship?
My wife is amazing, so I don't have the scans. I'm not reaching her level in terms of toolbox here. But I'd say it's also about staying very active, doing sports. Yeah. It helps me a lot. I don't have continuous therapy myself, just in the hard times. I need that. And also wanted to say that I'm from France initially. And in France, it's very difficult to get talking therapy. Typically, I mean, when you go and see a therapist, you will go and see a psychiatrist. So it's free, it's paid by the social system, and the psychiatrist will see you 50 minutes and prescribe you a drug. And you will see that person again in 1 month, 2 months, and that's absolutely not what I needed there. What I need is only someone to talk to, and that won't judge me, and that I can talk absolutely openly about everything.
Yeah. I think we do try to run together,
no,
but he obviously goes much faster than me, so
work.
it doesn't really necessarily work.
Is like 3 of you.
Yeah, exactly.
Ends up as a walk.
Yes. Great. I think that was really wonderful for all of you to be here. It's beyond altruistic what you're doing, to be up here, to be open, to be vulnerable, and share such intimate parts of your journey. I hope that it is inspiring to everyone who is here. I hope it's a way for all of us to connect and continue to work together to provide holistic and wonderful support to this community that we are all invested in. So thank you all for sharing. And I think, Lucia would like to close us off before we head to lunch.
I would like to say that so far, psycho-oncologists or psychologists providing support to cancer patients come too late on the process. Patients already suffered a lot for someone, a nurse or a doctor, to identify that there is a situation. We don't need that. We need that patients, and young patients particularly, they are in all the scientific literature that being young is the biggest risk for having, psychological suffering. So we don't need them to go through the suffering process to give them support. So we should do different. So as long as we know that this is going to happen, we should provide, as someone of you said, someone should have spotted that this was a long journey and provide me psychological support from the beginning so that I work out a mindset that will be helpful for me to go through this journey. And that's mostly what we do. It's not to put labels on people. We do not psychopathologize. That's something different. We help patients to cope with the situations, to decrease their anxiety by reducing their fears and their catastrophic thinking, by attaining to their reality, to learn new things like mindfulness, this and that, to help them keep focusing on their life. Sometimes we even say, the doctors will treat the disease, you have to keep on taking care of your own life because you're the specialist on this. So still invest on your things. So mindfulness, yoga, and so on helps you to nurture your mind and your body. So my call is that we should not wait until the patient is full of suffering. We should provide at the onset the psychological support for patients and also keep the carers into the angle. There is already a guideline for breast cancer young patients with breast cancer on this, to provide from the start and to keep the carer along so that, as I mentioned, both are attuned. So it's just replicating this for other cancers, and for sure, digestive cancers are one of the most challenging cancers that we can face. So I hope that the conference will help to put this in place.
I think that's a great way.
And thank you for everyone for participating in this session.
Thank you so much.
Thank you.
I think have some questions.
Are there any questions from the audience? We could do, I think, one or two maybe, or a bit later. Just one or two.
Hello, my name is Laure Chotel. I'm from France, and I'm a former caregiver and a patient advocate. I would like to come back to the question of the relationships with medical professionals, because, well, our journey, when my husband was diagnosed in 2021 with stage 4 colorectal cancer, and he managed to access 6 lines of treatment, and unfortunately he passed away last year. We managed in France to get real supportive care with very good healthcare professionals and psycho-oncologists, and also for the children, because we have 2 young kids. One who was 6 months old when my husband was diagnosed, and the other one was 2 years and a half. They are now 4 and 6 years old. But this journey, of course, was really, really difficult, and grieving now is, of course, also very difficult. And my question was about the training of the psychological training of healthcare professionals, apart from psycho-oncologists, who are, of course, specialized in the field and who are completely able to help. Well, they helped us a lot, and they are still helping me and my kids. But we also met some oncologists, surgeons, radiotherapists who were not trained in the psychological field. And for us, it has been very difficult to deal with some of them. So, I would like to know if this part is already taken into account in the training of healthcare professionals, and if not, why not? And could we do something for that? Because apart from our specific case, as part of my patient advocacy work, of course, I see a lot of patients and caregivers who experience rude relationships with their healthcare professionals. Some of them are sent back home, and where they are told that, well, I'm sorry, we don't have any more options for you. Go back home and die. It's not acceptable at all. And it's unfortunately quite common. So, could we do something for that? Thank you.
I can take, thank you. There's a lot for improvement in that area, in fact. I can tell you that there is now a global core curriculum by ASCO, the American Society of Clinical Oncology, and the European Society of Clinical Oncology, a global core curriculum for the education of medical oncologists that already have psychosocial care and psychosocial issues in cancer patients and communication skills as part of this core curriculum. This was firstly published in 2016 and has a new edition in 2023, just last year. I was part of it. There is a professional from Europe and another one from America. So that is being placed in this present and future. It's probably not in the present people that are providing the care yet. What we are trying to do is that continuous training involves communication skills training for medical professionals, because the way you communicate with your patients is of utmost importance for patients' adaptation and understanding of what is going on. It's already the first step of psychosocial care if you know how to communicate well, if you try to understand your patients and listen to them and understand what are their preferences and so on. So this is the first level of psychological support, is to empathize with your patients' difficulties and their resilience throughout their journey. But also they need to be aware, and you are right, about the psychological dimensions of the experience, that so as to be aware when their patients are in suffer and how to refer them for specialized psychological support. So there is a long way to still go, and I hope that patients' advocates will, as the European Commission is placing initiatives for the accreditation of units for the care of different cancers. I was involved in the breast cancer initiative done by the European Commission, and one of the areas that we focused, among all the others, was having psychological support as part of the accreditation, the requirements for accreditation, and also having continuous communication skills training for the healthcare professionals. So I hope that that will change the culture of the way that healthcare professionals relate with patients and carers, but there's still a long way to go, and all of us, and each of us here, are part of the change. So thank you for the question.
One more?
Yeah, thank you very much for sharing these interesting and intimate details. My name is Michael, stage 3 colon cancer survivor from Germany. You might remember me from before on the panel. One question from my personal experience is, I think psychological support of patients and caregivers during this difficult time is vital. How do you think we could even, the problem is not everybody has access to this, right? So there is a waiting time. In Germany, for example, I would have to wait 6 months to get a therapy place, you know? In the meantime, I dealt with it by myself. I could have been a private patient, but then, of course, there's this financial toxicity aspect of it. So how do you think we could lower this barrier, or maybe give an accelerated access for cancer patients? It's not only a problem of us gastrointestinal cancer patients, but cancer patients in general. How could we maybe elevate the urgency of these patients to get like a fast track to this very important part of their own journey?
It's really bringing the citizens to the politicians and say, look, 6 months waiting for psychological support, I can be dead by then. So what are you providing? It's like you should have a minimum of time, like for surgery. There is this, once you are diagnosed, you have a minimum of time to have the first treatment. Here, I think that we have to consider this, and that you have to show to the politicians what is the data right now. 6 months, it's not acceptable, but you have to show them, look, this is what we are getting. It's not enough. We want this to be at the same time as the surgery, as we are understanding the process. Because otherwise, it's we have already developed so much suffering that complicates the whole process. And it's going to be more expensive to the National Health Service, to the Ministry of Health, because it increases costs if it's not done properly. So you have to show them these numbers to make them think, well, it's less expensive to have psychological support embedded in the treatment than having to pay for all the extra costs of having people not going to work because they are depressed or not able, having family going apart, and so on. It's very expensive at the societal and personal level to not doing it properly. And I think that governments need to know that. And the data is already there. The evidence, it's there. So we need you. We psychologists cannot go by ourselves and say, we need more resources. We do that, but that's not enough. We need you to advocates to really go and advocate for this. Otherwise, it's not going to change, I'm afraid.
Maybe in the future, there is always a protocol of treatment. And I think maybe in the future, the treatment has to be seen like a holistic treatment. And probably it's necessary to have guidelines, for example, and maybe in the psychological support is necessary to put in the protocol.
The protocols published papers on essential requirement for the quality of cancer care in colon cancer, in many of the digestive cancer, pancreatic as well. But who puts it into place?
Exactly.
No one puts it. So we need this political will, this political strategy from everyone here to put this in place.
Require like a changes on a national level in every in a majority of countries. It cannot be just like a directive what recommends.
Exactly.
But I think what might help additionally as well would be to treat it a little bit like a business case, however it sounds. So try to find a positive case to see if there is a country who actually has this kind of process and how it works there. There might be some additional data published on a Ministry of Health or whatever, how much it actually costs in this country. Poland is not a perfect place, no dimension, especially not with psychological help. But actually, we have. It doesn't work perfectly yet. But in cancer centers, which is all of the parts of Poland, in the bigger city, there is at least one cancer center, and there is always a psycho-oncology unit. So the psycho-oncologists are already accessible in a hospital, and I was there for a few weeks and a few days, and I was in a hospital room of 6 people, but not a perfect place to have a conversation about your emotionals, but still better than nothing. And the psycho-oncologist was actually just going through one room to another, asking if there is hello, my name is this and this, I'm a psychologist, is there anyone who would like to talk? And of course, talking in your room with 5 other patients, it's like a disaster. I am not going to stop because you move a time is up sign. I need 2 more sentences. So of course it's not the ideal, and that would be some kind of an office when you can just sit and relax and feel comfortable and whatever. But there are some, and I'm not saying Polish has the best, the best example, but there is some kind of way to do this, and I think the best would be just to find this example how it works in different countries and have it okay, we have a know-how, we need to adapt somehow to our country specifics, but this is a doable. That's what we need to do. And then if there is any need for any patients organization involvement, we have some who would be super happy to help and hop on board and advocate for this.
I think there's so much more everyone could possibly say here, and we would need maybe a full day to even get to layer 1 of all the topics here. But unfortunately, we are way past schedule, and we should be heading to lunch now so that we can come back and start up again at 1:30. I think everyone here will remain for the rest of the afternoon. So if you have questions or you want to have a conversation, please use lunch or the next break to do that. Thank you so much.
I've been thinking about you. Oh yeah. wanna call, see if we're okay, babe. All I wanna ask you is, I don't wanna push you further away, no. I don't wanna play no games. I just wanna call, see if we're okay, babe. All I wanna ask you is, are you down for love? Are you up for someone to be together, be together? Babe, I want you. I'll be the one you trust. You never thought about it. Are you down for love? Are you up for someone to be together, be together? Babe, I want you. I'll be the one you trust. You never thought about this to me.
My life wasn't perfect, yeah, I know that now. When it came crashing down, all I know is that I need you around. When it comes crashing down, all I need is not to feel so much alone. So step inside my zone, baby, you can give me everything I want. Everything I want. Are all I need now. It's crazy, but it's true. You're all I need. You make my heart and spirit always dance and sing. You're captivating me. All I need is to know that I'm in your heart and never be apart. All I need is not to feel so much alone. So step inside my zone, baby. I can give you everything you want. Everything you want. Are all I need now. It's crazy, but it's true. You're all I need. And I know everything will be alright. Wanna go, wanna go, wanna go, wanna go now. Take me to your paradise. Yeah. You are all I need. Are all I need now. Yeah. It's crazy, but it's true. Crazy, but it's true. You're all I need. dark until the first light of dawn. Just like fate without no warning. It hit me so hard. Oh, I'm so sorry, girl, I didn't mean to. I done messed it up again. Yeah, I'm sorry if I crossed the line. What am I supposed to do?
pouring rain. And no matter what we go through, love will still remain. So do what you want, baby. You and me in the sun. Know that I still be here when the day is done. So come a little bit closer, and I'll tell you what I feel inside. You know I'm gonna wait on you. I'm gonna wait on you. You know I'm gonna wait on you. Yes, I'm gonna wait on you. No one's gonna love you like I do. So glad that I found you. You're the missing piece, the last piece of the puzzle. I'm finally at ease. So when times are rough and the promises we make just seem so hollow and weak, and we're about to break, we have to remind ourselves, 'cause we know how we feel inside. You know I'm gonna wait on you. Ain't over till it's over. I'm gonna wait on you. I'm gonna love it till it's gone. You know I'm gonna wait on you. And the weight that's on your shoulder, I'm gonna carry that for you. So hear me when I say, no one's gonna love you like I do. I'm gonna wait on you. I'm gonna wait on you. You know I'm gonna wait on you. And the weight that's on your shoulders, yes, I'm gonna carry that for you. So hear me when I say, no one's gonna love you like I do. Let's fly away, just you and me. I need a little break from the city. It's been so long since we've been gone. I wanna feel that summer feel, but I don't wanna go if you ain't with me. Let's make a home, be all alone. So tell me, baby, where would you like to go? Maybe we'll drive from coast to coast, only to where we love the most. I'm taking you to paradise, paradise. You know where we're going tonight, going tonight. Paradise, paradise. I'm taking you to paradise, paradise. I don't even care about the price, care about the price, yeah. Paradise, paradise. I'm taking you. Let's see the sun and have some fun. I'm so tired of living life in gray, babe. And you deserve to see the world. So tell me, baby, where would you like to go? Maybe
too close. Don't need to where we love the most. I'm taking you to paradise, paradise. You know where we're going tonight, going tonight. Paradise, paradise. I'm taking you to paradise, paradise. I don't even care about the price, care about the price, yeah. Paradise, paradise. I'm taking you. Come and take a seat next to me, babe. Let this pretty view take your breath away. Baby, we deserve a break from our old ways. Anywhere's home when you're with me. Come and take a seat next to me, babe. Let this pretty view take your breath away. Baby, we deserve a break from our old ways. 'Cause I'm taking you to paradise, paradise. You know where we're going tonight, going tonight. Paradise, paradise. I'm taking you to paradise, paradise. I don't even care about the price, care about the price, yeah. Paradise, paradise. I'm taking you, you, paradise.
Ever since we met last night, I've been trying to keep my distance. I just wanna play my cards right. It takes one false move and you'll be gone. But maybe it's alright. I can't tell if it's the right moment, but baby, anyhow, I can't hold it in anymore. 'Cause it's starting to come out, starting to come out. I've been holding it for too long. Yeah, it's starting to come out, starting to come out. And I can't pretend anymore. Oh, I'm yours. Never thought I'd even try. After just one day, it's special, yeah. But there is something in your eyes. Ooh, one false move and you'll be gone. You maybe, it's alright.
Yes.
I can't tell if, baby, it's the right moment, but baby, anyhow, I can't hold it
It's the end of the weekend, but I still wanna turn up. Yeah, I still wanna turn up. All I want is to go again, but you ain't picking your phone up. Why you messing my head up? Any night, any day, let me take you away. All I need is just saying yeah, 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 yeah. Better nights, better days, when you're here with me, babe. Cause you're all that I crave, so I wonder, where are you? Where are you? Where are you? Don't hide away from me when I need you most. We got love guaranteed, and I have to know, say, don't be so hard to reach. Just pick up your phone. Tell me where you'll be, cause I gotta know. Let me know when you're ready, cause I made reservations. Too many invitations, and the last night was heavy. I need communication. Tell me where's your location. Used to talk 24/7, every other second, just to make sure we were up to date. Now it's closer to 11, and I ain't hearing nothing. I just need to know that you're okay. Don't hide away from me when I need you most. We got love guaranteed, and I have to know, say, don't be so hard to reach. Just pick up your phone. Tell me where you'll be, cause I gotta know. Any night, any day, let me take you away. All I need is you saying yeah, yeah, yeah. Better nights, better days, when you're here with me, babe. Cause you're all I crave, so I wonder, where are you? Baby, don't hide away from me when I need you most. We got love guaranteed, and I have to know, say, so hard to reach. Just pick up your phone. Tell me where you'll be, cause I gotta know. Just pulled up to the house, don't feel like getting out. I'ma just lay back and crack this window. I've been doing my best, taking a moment to rest, feeling stressed out. Give it a cut, I put that on guard when it gets hard. I stay on my job like no days off, so you can go with the negativity, with that low mentality, jump on jealousy, my bad. Get away from me, cause I've been working all day. Can a nigga catch a break? Give a pretty brown girl her space. You can keep your bitter, I'ma make a better way. Hey, hey, already got the world on me. Give a pretty brown girl her space. You can keep your bitter, I'ma make a better way. Hey, hey, catch a break, better way. Oh, Mom and Dad's only daughter, do I make you proud? Writing my life in lyrics, do y'all like the sound? Seeking approval constantly. When it's my truth I own, I speak it, don't make sense now. Give it a cut, I put that on good when it gets hard. I stay on my job like no days off, so you can go home. my heart says. I wanna be with you always. You are my world in every place. It's the things that you do, and it's the smile on your face. And as time goes by, I know I'm in a better place. I'm in a better place. Without your love, I am out of place. And without you, I am just a trace. I love you with all of my heart. Together forever, never to part. I wanna be with you always. 'Cause that is what my heart says. That's what my heart says. I wanna be with you always. Always, yeah. You are my world in every place. Oh, oh, oh. It's the things that you do. It's the things you do, baby. And it's the smile on your face. Smile on your face. And as time goes by, I know I'm in a better place. I'm in a better place. tears down on the table, knowing there's no way that you'll be able to win this one. But she's somebody else in the making. First, she's just gotta stop all the faking, and she'll be there. But she's wondering if it's gonna feel like she's forever. Wondering if it's gonna feel like she's whenever she leaves her safe space. She leaves her safe space. Wondering if it is forever, or is there some place that will make her feel better? Make her feel better. Then that's where she'll go. That's where she'll go. Somebody said, don't be afraid of loving yourself, 'cause that is all you got in the end. You got in the end. But she's wondering if it's gonna feel like she's forever. Wondering if it's gonna feel like she's whenever she leaves her safe space. She leaves her safe space. Wondering if it is forever, or is there some place that will make her feel better? Make her feel better. Then that's where she'll go. That's where she'll go. Talking to myself 'cause I don't know what I want. Yeah, I'm here talking to myself like someone's gonna respond. I'm getting tired of myself 'cause I don't know what I want. But I'm not out here on my own. Wondering if it is forever, or is there some place that'll make her feel better? Make her feel better. And that's where she'll go. That's where she'll go. That's where she'll go. That's where she'll go. Yeah, that's where she'll go. That's where she'll go. Talking to myself 'cause I don't know what I want. Yeah, I'm here talking to myself like someone's gonna respond. I'm getting tired of myself 'cause I don't know what I want. But I'm not out here on my own.
Afraid, emotions getting in your way. Afraid, but why you let me fall in love if you're afraid to commit? And don't call me in the middle of the night and say that you're not able to be loved. That's not right. No, I don't wanna be that one. Still a million miles from you, so I'm gonna let you go. Oh boy, if you only knew. Not a day goes by without you on my mind. You couldn't go on together. You said nothing lasts forever. Though you can't deny, hold it all inside. No, you can trust me, just close your eyes, knowing that I'm around. I'll be around.
And I don't know if you have heard that in my world you're the light. Yeah, yeah. So buy me time, oh buy me time, baby. Oh, I know it's in the late hour. I've crossed the line too many times. Can I ask you for one more
can get started. Our next speaker is running short on time, and he is dialing virtually. So let's go ahead and get started with our next session. I hope everyone has had a good lunch. You grabbed a coffee, and you're ready to go. We will now look towards future implications for prevention, research, and practice for early age onset digestive cancers. And our first speaker will be Professor Florian Lordig from the University of Leipzig. He will join us virtually, and he is there already. I'm so sorry for the delay, Professor Lordig, but the floor is yours. Please take it away.
Hello, it's so nice to see you. And I see there are many people in the room, and I think my screen is shown on your on your display, so that works. I'm very happy to be with you. Unfortunately, not in person because we have a parallel meeting of the ERTC. But thank you for inviting me online. And I will try to share my screen now. I hope that this will work. Wait, here comes the presentation. So that should be visible now on your side.
Perfect.
Good. The task given to me was to tell you a bit of what we know about the occurrence of gastroesophageal cancer, with a focus, what are we doing that healthcare professionals better understand how to deal with that. It's a broad topic, but I chose some of the aspects which I find quite interesting and also innovative. And here I show you a personal disclaimer of potential conflicts of interest, but I think they are really not of importance in this context here now. Gastroesophageal cancer, at least we have to say we have two very different histologies. There are some very rare ones as well, such as sarcomas of the upper GI tract, but mostly when we are talking about that, we are talking about squamous cell cancer, which we find in the esophagus, and adenocarcinoma, which we find in the esophagus, in the esophagogastric junction, and in the stomach, of course. These are important diseases. I'm starting here with some aspects which might be important for you to know about gastric and esophagogastric adenocarcinoma. This is really a very important disease from a worldwide perspective. Number 5 in terms of incidence, number 4 in terms of cancer deaths, which also shows you how aggressive this disease, adenocarcinoma of the stomach or EG junction, can behave. We are talking about 1 million new cases per year. And it's very interesting for us for many reasons that the geographic distribution is quite heterogeneous. I show you here on the left-hand side, the typical picture for esophagogastric junction cancer, which is very prevalent also in Europe. And here on the right-hand side is the picture for classical stomach cancer, which is most prevalent in the Asian parts of the world, especially the East Asian, but also East Europe, and also very prevalent in Latin America. So the geographic distribution is quite different, which shows already that this is a disease based on different backgrounds. The classical gastric cancer had a decline in incidence worldwide. That's something quite interesting because obviously, some of the risk factors are not that prevalent anymore in many parts of the world as they were in the past. Nevertheless, we have to say, due to the aging world population and due to the increasing world population and also the population which is increasing in parts of the world where this cancer is very prevalent, such as East Asia or Latin America, overall, the global burden of this malignancy is expected to have a 62% increase by 2040, even if the incidence in the Western world, like here shown here for the US, is decreasing. When we are going into details about risk factors for gastric and esophagogastric adenocarcinoma, we can easily detect the differences. And for the classical stomach cancer, still the most important risk factor is the infection of the stomach with Helicobacter pylori. 90% of classical stomach cancers are associated with this infection. And that's really important to know, because this is something we can work on, because as probably all of you know, we have treatment for H. pylori infection. And other risk factors are cigarette smoking, diet rich of salt. So that's typically important for those regions where food has not been stored in the refrigerator, but has been packed into salt for keep it consumable. And also the consumption of processed meat and alcohol consumption plays a certain role. And the risk factors are certainly different for cardiac cancer. Helicobacter pylori cancer infection is not that important there. Cigarette smoking is important. A BMI, which is above the normal range, becomes very important. And then something which is really important to know, when risk factors come together, like for instance for gastric cancer, Helicobacter pylori infection, and cigarette smoking, or higher salt intake, then the risk really increases enormously. So that's something that healthcare professionals really should be aware of, to inform the patients, to identify the risk populations. And there is a smaller group of patients in who gastric cancer and the occurrence of gastric cancer is associated with hereditary factors, with risk genes, which are typical for this individuum. And the younger a patient is at the diagnosis of gastric cancer, the higher the probability is that you find some of these risk genes. It's important to know the association between E-caterin mutations and gastric cancer. Also APC mutations can play a role, but E-caterin is really something we need to identify, because it's associated with early occurrence of gastric cancer. And this is important for the whole family to know. So if we identify young patients, they really have to undergo genetic testing, not only to inform the patient for potential future risks, such as for breast cancer or other risks, but also to inform the family. That's super important, because these families, they have a real high risk to experience gastric cancer. And from the same publication here from last year from the New England Journal, it was also shown again, if these genetic risk factors come together with a Helicobacter pylori infection, then the risk increases enormously. So especially in those patients, we should do everything to treat these Helicobacter pylori infection. And does it help to treat Helicobacter pylori infection in healthy individuals? And I think yes. I mean, there is ongoing discussion about that point since decades, but more and more data indicate now that you really can reduce the risk if you treat people in who the stomach mucosa is infected with Helicobacter pylori. This is a study from California, from the Kaiser Permanente database. A lot of individual data went in here. And they are showing here the cumulative risk for developing gastric cancer for people who have no Helicobacter pylori infection in their history. And for those who have a Helicobacter pylori infection in their history and did not get treatment eradication for that, they have a much higher risk to experience gastric cancer. And if this Helicobacter pylori infection is treated, if they get an eradication, the risk really goes down. But it takes some time. It takes approximately 8 years to show that the risk goes back to practically normal. But for me, these are all important indicators to treat that risk. If a detection of Helicobacter pylori infection is done. And when I'm switching now to esophageal cancer, and here we are talking mostly about squamous cell cancer, this is really a completely different disease, again with different risk factors. It is very prevalent in East Asia, and it is also very prevalent in parts of sub-Saharan Africa. Some of the risk factors are really known, such as cigarette smoking and heavy alcohol drinking, something which is really not only important for preventing lung cancer or pancreatic cancer, it's also an important risk factor for esophageal cancer. And this is an important disease, 500,000 new cases per year from a worldwide perspective. And I was always sad to see that the African region was so much neglected for a variety of reasons. So I'm very happy and proud to say that by the beginning of this year, we got funding of a joint project with our African colleagues. We started an initiative which we call Africa Connect Project, African Initiative Against Esophageal Cancer. And many colleagues from the East African esophageal cancer belt are involved in this project from countries such as Ethiopia, Kenya, Tanzania, Malawi, Botswana, South Africa. You can see these wonderful colleagues here together with the European and US colleagues who are helping with this project. We had a first kickoff this February 2024 in Nairobi. And this contains a lot of important initiatives. Work Package 1, for instance, is about raising the awareness of stomach cancer because so many patients on this continent are diagnosed late, much too late for providing curative treatment. But another work package goes on surgery, another on endoscopy, another on pathology, another on multimodal treatment. And we are trying to train centers there and to bring some of the colleagues also to Europe to learn new technologies. A couple of weeks ago, we started with a series of multidisciplinary tumor boards where European and African colleagues meet now on a monthly basis to discuss problems around esophageal cancer and discuss specific cases. So that's a wonderful initiative in my view. And I'm very grateful that the International Cancer Foundation is giving funding for this project. What we are seeing mostly when we are talking about esophageal cancer in many of the Western countries, such as the one where I'm based, Germany, but also in the UK, Netherlands, in the US, Canada, is esophageal adenocarcinoma, the other histologic subtype. And this is a disease, as this picture wants to indicate, which is massively associated with gastroesophageal acid reflux, because this causes constant inflammation in the lower parts of the esophagus. And this inflammation ultimately can lead to the cancerous transformation of the esophageal mucosa. And this is a phenomenon that was started to be observed in the 1980s, 1990s. And meanwhile, we can say that esophageal adenocarcinoma, which is also called Barrett cancer, has the sharpest increase over the last 3-4 decades of all cancers. And so you see a lot of probably civilization factors and behavioral factors that goes into that direction. And we do not understand everything, but we know that male persons are more affected than female persons, much more. There is a distribution of 9-to-1 for this disease. We also know that it is associated with male obesity, the visceral type of obesity, which may cause gastroesophageal reflux. And the picture that you can see schematically is that the first step is the inflammation of the esophageal mucosa, and then it gets to repair mechanism and to a transformation of the esophageal mucosa. There is a new type of esophageal mucosa with a glandular phenotype, which is built there. And on the basis of that, cancer can occur. And it's so interesting for me. This is a bit of scientific picture, but I try to explain that to you. What meanwhile research has found out that early on there can be islands of this transformed mucosa where you see genetic transformation which goes into a malignant development. But for a long time, probably, and for some patients for a lifelong time, the immune system and the normal mucosa can control for that and can also push it back. There is a certain equilibrium. But then at some point, at least for some patients, suddenly some of these clones with carrying important mutations can break out and can lead to this malignant transformation that leads to cancer. So this is really what we need to be aware of, and we need to get better in identifying those patients who are at real risk that this dysplasia breaks out and leads to cancer. This is another way to show that. And there are, of course, now several attempts to identify risk patients. This is an interesting study that is currently done in the UK under the guidance of Rebecca Fitzgerald, who sits in Cambridge and has built a wonderful British network. And this technique, which is shown and displayed here on this Lancet publication, is called the cytosponge technique. And what people have to do here is to swallow a sponge, which is connected with a wire to the investigator. And then when the sponge is pulled out, it contains parts of the esophagus that can be of esophageal mucosa, which can be investigated under the microscope. And when the microscope shows some alterations which are characterized by a specific protein here, which is called TTF, that can be a sign that this malignant transformation has started, and patients can be referred to upper GI endoscopy, which then shows probably these islands of transformed mucosa. Here, this whitish one is the normal one. This reddish one is the one which is transformed, and the investigator through the endoscope can take different biopsies here, many biopsies that can be further investigated under the microscope and can show early forms of transformation which can become dangerous for the patient. And another very interesting European-funded initiative is this project, which is called TOGAS, and Digestive Cancers Europe is also involved. And it's a massive project into which many countries in Europe are involved. And it is not focused on esophageal cancer. This project is focused on gastric cancer. And it's also about different research approaches that try to identify early the patients who are at risk, the people who are at risk to developing gastric cancer. One of these initiatives is, for instance, to do an upper GI endoscopy together with the colonoscopy, which is already implemented in many countries in Europe to identify early risks for colon cancer. So if a gastric endoscopy is done in parallel, they could also see early alterations of stomach mucosa, which contains pathology which might lead into gastric cancer. But there are also other research parts of that, and maybe in the future, specific phenotypes of the patients, but also specific genotypes might indicate those who are at increased risk for developing gastric cancer. So this is what I wanted to show to you, and I'm very happy, of course, to discuss things with you and also receive your comments on that. Thank you very much for your kind attention.
For your amazing presentation. I'm so sorry for the delay and that you had to wait. Do you have time to stay and take a question or two?
Oh, yes, of course, I do. Absolutely.
Is there anyone from the audience who would like to ask a question from Dr. Lordick? Now is your chance. Or if you would rather send it in via email, we can connect to you that way. No? I think we're okay then. Thank you so much, and have a good EORTC GI tract meeting.
Yeah, thank you so much, Natasha, and many regards to all of you, and enjoy this wonderful ENTERO meeting.
Thank you so much. Bye-bye.
Thank you.
So, in the interest of time, since we are running behind schedule, our next speaker, Professor Julian Taib, was unable to join us, and he had sent in a recording that we were scheduled to play, but we will have that uploaded on our website for you to view at a later time. And I think now we can move on to Dr. Karen Papier, who joined us literally from the airport about 5 minutes ago. She's from the University of Oxford, and her work emphasizes lifestyle factors and prevention strategies. So she will guide us through how certain lifestyle choices can significantly impact cancer risk and the importance of integrating these strategies into public health initiatives. Thank you so much for being with us, Karen. Welcome.
Is there a clicker?
Yes.
Thank you. And I'm going to blame jet lag if I'm slow or anything. So it's really nice to be able to be here with you, and a pleasure to be able to talk about one of my favorite things, lifestyle factors and prevention strategies. I wanted to kick off with this. 2 articles from the same newspaper. So on your left-hand side, sorry vegans, Australian study finds eating meat correlates with a longer life expectancy. Published 23rd of February 2022. The next day, 24th of February 2022, you've heard of meat-free Mondays, now try tofu Tuesdays. Cutting out steaks, bacon, sausages for 2 days a week can slash your odds of cancer by 10%, study claims. I guess this shows a few things, but 2 that immediately come to mind is that the media doesn't always exactly pick up the nuances and studies that we put forth, which makes it quite difficult for the readers. And the fact that it's in the newspapers every single day suggests that people are interested. People want to know about diet. People want to know about lifestyle factors. People want to know what they could be doing to prevent different diseases, right? And they should have an interest, because indeed we are in trouble. We've got a lot of non-communicable diseases causing a lot of deaths all over the world. Cancer, as many of you in the room would well know, is the second leading cause. This is looking at 50 to 69-year-olds, which is still premature mortality, lower than 70. Over here, when we're restricting it to 15 to 49-year-olds, again, we're seeing that cancer is still the second leading cause of premature mortality. So over 2/3 of deaths are caused by non-communicable diseases. Cancer is the second most leading, and 5 million people are dying prematurely each year, meaning below the age of 70 from cancer. So clearly we need to do more about this. We're failing on prevention, sad to say, myself included. So what do we know to date? What affects cancer? We've just heard in the nice talk before a bit about genetics, and of course genetics, cancer is also a disease of genetics, but the majority of cancer is sporadic. So we have things like infections, which we heard about for gastric cancer just before, also environmental factors, so for instance, the sun, for things like skin cancer, reproductive hormonal factors, and several different lifestyle factors. And the World Health Organization estimates that about 30 to 50% of cancers could be prevented, which shows the role of lifestyle factors and how important it is that we can modify these. So I thought I would just, given the topic of digestive cancers and early onset, just hone in a little bit on some of these factors that relate to digestive cancers. So starting with overweight and obesity, this is associated with several different types of cancer. So having overweight and obesity, having a larger body size, often measured by body mass index, you could see several of the cancers are digestive cancers. And we know that in adulthood, we want to try to maintain a healthy weight where we can. And traditionally, with kids, in adolescence, it's not been too much of a problem, but the story is changing. Thinness across the world is actually going down. So where we think that we have a lot of thinness all over the world is not the case. We're seeing a lot of a double burden of malnutrition, where we have people who are both overweight and underweight in the same country, in the same household, in the same community. And you could see that even as young as 5 to 9, and also in adolescence, overweight and obesity is going up. It's really hard to lose weight, especially when you're starting early on in life. And basically, the longer you have an exposure for, the worse it's going to be for your dose response, right? So if these kids and adolescents are starting off being overweight and obese so young, that's a long time of exposure, increasing their risk for digestive cancers in the coming years, sadly. Alcohol is associated with these 7 cancers. Notice the majority of them are digestive cancers. And alcohol is a really interesting one. I'm living in the UK, so you basically can find alcohol anywhere, which is it's very cultural, right, to drink it. But no alcohol is good for cancer, none at all, right? And in terms of who's drinking it, here in Europe, it appears to be quite popular, according to the WHO region. It seems to be also something that is consumed as GDP goes up. So as a country gets more financially stable, consumption of alcohol tends to go up, which makes sense, right? You can start to afford some of these things. A lot of the world is going through an epidemiological transition where countries are transitioning from low to middle to upper middle income countries. So that means consumption of alcohol is just going to keep increasing. So what we might expect in the next few years, of course, more digestive cancers. Now, binge drinking, is that a term that you use in Europe? Definitely a popular one in the UK as well. This is some data from the UK that basically it's drinking a lot. So when you're sitting and drinking, you're drinking far too much. So this is among people who were consuming alcohol in the last week in the UK. How many of them binge drank, which for men is more than 8 units in a single day, women more than 6 units in a single day. So it's a fair bit in one go. There's a little bit of kind of movement around over the years, but notice that down the bottom are the older folk. They're not the ones doing the binge drinking. It is the younger adolescents. I mean, who's giving them alcohol at 16? But that's a different question. But it's the younger adolescents, it's the younger adults. So of course, more years of exposure, harmful substance, what we might expect for digestive cancers moving forward. Now, I thought I'd come back to diet because my research area is on diets. I want to spend a bit more time on diets, both healthy and unhealthy. So what do we know about diet when it comes to digestive cancers? So I've adapted the information from the World Cancer Research Fund, which has a continuous update project, and in 2018 published its last report. So I've removed alcohol because we saw alcohol. Alcohol is terrible and it's associated with ever so much. So these are the other dietary factors. So the way the World Cancer Research Fund classifies the strength of evidence is that the strongest evidence is considered convincing, which is that we're convinced that this is definitely causing cancer. After this comes probable. The difference between what makes something convincing and is probable is a little bit debatable. It tends to be that convincing evidence is biologically plausible, it's consistent, there's different types of data. You might have trial, you might have genetic, you might have observational where we ask people what they're doing and follow them up over time. Or it might be that everything's been consistent even if there's not a lot of data. For probable type of evidence, sometimes you have a lot of consistent information, but maybe the numbers are too small, or maybe a trial didn't find it, but all the observational data did find it. So sometimes things that are here maybe belong there, but maybe it's just a matter of time. So in terms of the things that's up the top convincing, you'll notice for food, it's really just processed meat, and it's for colorectal cancer. So those two headlines earlier had something mixed up in the first slide, right? So the International Agency for Research on Cancer in Lyon classifies processed meat as a carcinogen. So that means that it's a level 1. It's the same level as a smoking and alcohol. That doesn't mean that it has as much of an impact. It doesn't mean that the relative risk is as big. It just means that the level of evidence, they're as confident as they are for things like smoking or alcohol. Unprocessed red meat, 1 level down. So that's considered a group 2 carcinogen, which is in line with what I'll go back and show you for unprocessed red meat. And there are several mechanisms by which processed meat and unprocessed red meat are thought to increase colorectal cancer. You'll need to memorize all this by the end of the talk, but it's a lot to absorb. But I mean, I guess processed meat, because it's a convincing one, a really one that we're quite confident with, is nitrates, these salts that you add to the meat as part of the preservation process that can then turn into nitroso compounds, which can then be mutagenic. So this is just a group of some of the mechanisms for red and processed meat. So unprocessed red meat is down with, is he over there somewhere? Is he over there? Oh, goodness. Good for noticing. It's also probable. It's not convincing. But we have all these other things that come up as probable, and most of them are for colorectal cancer. So you'll see a lot around sort of foods rich in fiber and foods rich in dairy. And this is really interesting because you think these are things that we do consume widely. For instance, in the UK, love a cup of tea, right? So you're adding dairy, you're adding milk all the time, fiber in a lot of the different European countries, a lot of different types of whole grains are being consumed. So it'd be really nice to know if these are things that we already do promote for prevention, but can we find them convincing? So what's missing? Potentially consistent research. Potentially, sometimes people publish on things because maybe they want it to get published or because that's what they collect information on, not because it's not true, just because it may not have been studied or sufficiently. So we wanted to look at it thoroughly. So we conducted a diet-wide study in the Million Women Study, which, as the name suggests, it is a huge study of 1.3 million women who were recruited through breast cancer screening centers. They were recruited between sort of 1996 and 2001, and since then, every 3 to 5 years, we've been sending out a questionnaire. And the questionnaires might have a different focus. So the questionnaire they got 3 years after recruitment, which I highlighted in red, had 130 questions on diet. So we could use that to look at their different dietary factors. Remember, sometimes things are probable because maybe there's not enough consistent evidence from different types of data. So we thought, okay, let's see if we can let's see what we see in the diet in a really big study, and let's see if we can see any concordant evidence from genetic data. So we used a really large GWAS, so it's 99,000 participants, about half of them have cases of colorectal cancer, and it's a combination of really large data looking at a meta-analysis, basically combining information on different SNPs and GWAS that have been found. So the actual analysis for the Million Women Study part, we took about 542,000 women who didn't have any cancer at baseline, and we looked at 97 dietary factors, so different foods and nutrients in relation to, bless you, in relation to colorectal cancer. We have 12,250 cases in these women, so this makes us the biggest single study of diet and colorectal cancer ever done. It's a phenomenal number. It's phenomenal to think about that many people with colorectal cancer. And we look to see how is each individual food associated with the risk of colorectal cancer. For the genetic study, what we did is we don't have genetic instruments for every dietary factor. We have one for alcohol, and alcohol we already know is established convincing risk factor for colorectal cancer. But we do have a really good instrument for dairy intake. So to be able to digest dairy, you need to have an enzyme called lactase, which breaks a sugar in the dairy called lactose. It literally needs it to break it in half. So you may be genetically disposed to keep producing this enzyme and be able to break the lactose. So if there's anybody here with like a lactase pill in their pocket to be able to drink a cup of milk, you probably can't do that anymore. You're probably having a hard time making this enzyme. So it's a really good way to be able to see, usually if someone isn't able to produce this enzyme, they usually don't have a lot of dairy because they feel terrible when they do, unless I guess they're carrying that little pill. So it's a really robust instrument that we can use to look at the evidence. So what did we find? This is a volcano plot. If anyone hasn't seen one before, the name from the kind of erupting results. So what you have on the bottom is relative risks. So these are whether something is associated with higher or lower risk. So anything from above a 1 suggests that whatever it is associated with a higher risk of colorectal cancer. Anything below the 1 is a low risk. Anything that sits on the 1 means nothing, because you can't be both a higher and a lower risk of something. There's 97 things, so there's a chance that we're going to find chance findings. So we try to correct for something called multiple testing, which is to try to eliminate as much as we can from chance findings. So anything in gray, we kind of think, maybe this is chance, we don't pay much attention to it. Anything in pink, we do pay attention to. So if you look at the pink area, the thing with the highest, which is the strongest association we saw, was alcohol. So we see that per 20 grams higher alcohol consumption, 15% higher risk of colorectal cancer. Consistent, this is what we know from the literature. We know alcohol is not great for colorectal cancer. Moving to this side means that we have lower risk. Calcium is up next, like way up above the crowd after alcohol, right? So it's a really exciting finding. So per 300 milligrams of calcium, 17% lower risk of colorectal cancer. And just below calcium are hanging out a few of the dairy friends. So we've got dairy, riboflavin, things that tend to go together with dairy. So if you're having a cup of milk, you're probably getting the calcium and the riboflavin. So it makes sense they go together. Next to that, you have some fiber, whole grain related items. Remember, we saw that before. And there's red and processed meat associated with a higher risk. So first of all, if you find something you know you should find, it's a good sign. It means the data are doing a good job. And this is basically everything that was listed as probable. But really what's phenomenal, I think, is the calcium in dairy. They're just so strong. And when we did the genetic analysis, we found that per 200 grams higher intake of genetically predicted milk, which is something to wrap your head around, there was a 40% lower risk of developing colorectal cancer. So that means it makes sense that the association is going to be stronger in a genetic analysis than an observational analysis, because genetic is a lifelong exposure, whereas this is not a lifelong exposure. It's somebody wrote down what they've eaten. It's not forever. But we're seeing a consistent result. We're seeing that the genetic results are supportive of what we're seeing observationally, which I think is really exciting. So some other ongoing research in the field, dietary patterns is something that's being studied widely. We're not too confident yet to comment what the best dietary pattern is. For instance, the World Cancer Research Fund has a diet pattern made up of all the things that they found to be associated with high or low risk. If you think about something like a plant-based diet, naturally it's going to have less things like red and processed meat. It's going to have more fiber, but it might also have less dairy. So watch the space. How is that going to balance out, right? What else? Microbiota is an area that's being looked into a fair bit to understand, well, what's the gut doing? And is it increasing the risk of digestive cancers, or is it helping lower the risk? And some biological mechanisms linking different lifestyle factors like diet and physical activity are underway. And I just wanted to briefly share one that we're working on that I think is just really exciting. So the last talk we spoke a little bit about proteins, and we used to study things like 1 or 2 or 3 proteins at a time, like insulin growth factor 1, or just a handful. We now have methods and like techniques to assess thousands of proteins in people's blood. And there's up to 20,000 proteins in our bloods, and these have so many important roles. So we took the UK Biobank, which is a large cohort study in the UK, accessible to anyone in the world. And what they did was they measured plasma proteins. At the time, it was 1463. Now it's doubled in about 50,000 people. So we took all the people from the 50,000 who didn't have cancer, about 45,000, and wanted to see, well, what happens over 12 years of follow-up? How are these blood proteins associated with the risk of developing cancer? So we looked at 19 different cancers, 9 different cancer subsites. And here's another volcano plot. Everything above the orange line means that we're confident in these results. We found 618 significant associations between proteins and cancers, and 107 of them were still there 7 years. So if you had your blood taken 7 years before you even were diagnosed, we still saw it, which is really exciting when you think about cancer development. Because usually, if you see something and it's within a year of developing cancer, you think, well, did the cancer lead to something weird in your blood levels, right? I'll just draw your attention to the loads of green dots down the bottom. These are liver cancer. So we're getting lots happening for some of the digestive cancers. So the next step is to say, okay, well, proteins are really important for cancer and biological processes, and they're affected by environment. So how does diet, how does physical activity, how does overweight and obesity, how do all these preventable factors affect these proteins and their levels? And then can we change our protein levels and potentially have an effect on preventing cancer? So it's so important that we can collaborate to keep doing this work. So for instance, being able to work together with colleagues to combine genetic evidence with our observational evidence makes us more confident about, for instance, the dairy and calcium finding. Also, numbers and diversity. So especially for early onset digestive cancers, a lot of these older cohorts were recruited in the 90s or early 2000s, and they tended to focus on middle-aged adults. So you have a lot of 60, 70-year-olds. See, when you want to try to look at someone who developed cancer at 35, there's just not enough people. So if you can work together across cohorts, we can try to get a better idea of what's going on with bigger numbers. Finally, we have all these really new promising avenues and new techniques, like with the proteomics, to try to understand how do things connect together to help us prevent going forward. So briefly to conclude, cancer is a leading cause of premature mortality worldwide, and identifying potential risk factors is a priority if we want to do something about that. Many cancer cases can be prevented. So really, individuals with the support of their communities and really to be able to afford to be able to make changes need to be able to adopting healthy lifestyles from what we know that's established to help with digestive cancer prevention. And just to remind you, these are some of the really established risk factors and things we can be doing and working on to help prevent our risk of digestive cancers. So thank you very much. It's really nice to be able to be here in person, and to all the participants who make this research possible. Thank you.
Thank you so much, Karen. Do we have any questions? We have a little bit of time, but not too much. It's coming.
Check, check, 1, 2. Hey, Karen, my name is Michael from Germany. Thank you for this very interesting talk. My question would be around the fasting aspect of diet. So there's been some studies showing a positive correlation between fasting and cancer risk, or like even if you are a cancer patient, then you might beat the cancer cells with fasting. Can you comment about this quickly?
I think it's a really interesting question. I think the data aren't there yet, though, because it's a question that people didn't include in a lot of these really large surveys. So maybe potentially in clinic or where you're working with people and you can ask them more immediately, maybe that's something that, I guess trials are really difficult to work with, right? Because no one's going to give you 15 years being locked up and letting you wait till they develop a cancer. So it's really hard to study that in a trial. So the best way to do it is observationally. And there are so many good questions that people didn't think to even include over the years, and now they're thinking about it. And I know people are trying to use accelerometer data to try to get an understanding of, did somebody fast? So for instance, things that they were for physical activity, people have been measuring, well, if someone's doing this 10 minutes straight, are they eating? Are they brushing their teeth? If they didn't do this, are they fasting? So I think people are trying to be creative to see how you can study that, but I think to collect those questions is really the best way to try to understand, is it important?
Are there any more questions? There's one more. Okay.
My name is Niamh from Ireland, bowel cancer patient. I'm early onset, but not as early as many of the people that we've actually seen here today. And one of the questions I want to say is, knowing that adenocarcinomas in particular can take 10 to 15 years to actually develop, how relevant is some of this information to do with certain lifestyle factors, leaving out the obesity part? We know how that leads to so many other things. But how upsetting it might be to maybe some of the patients here who were in their 20s and early 20s and none of these risk factors applied to them whatsoever, that it almost infers or confers a blame. And I wonder how that is intended to be addressed and how we are looking at the other factors outside of these that are particularly not relevant to as many of the younger people that are being diagnosed.
I think that's a brilliant question. And while I know some folks are working on trying to understand, like you're saying, are some of the traditional overweight, obesity, what happens once you've been diagnosed going forward. Some people are working in that space. I really think the proteomics is really exciting here, because I think if we do see something that's changing or levels that are changing within a year, and there's a way to risk stratify, or there's even drugs that we know that are good for some proteins, and if we can maybe knock these proteins out and actually help somebody at the time that they need it, I think that's going to be really exciting going forward. So I know there's work happening in tissue lines and trying to understand, okay, so if we found this protein that we know genetically is causally associated with this cancer, and this person's coming in with it, can we see what happens if we put it in a mouse model or if we're putting it in tissue? Is it going to knock it out? And if it knocks it out, does that mean that their risk is going to go down, or that they're going to be having, like in live motion, they're coming in right now telling you, I've got this protein, I've been diagnosed. So I think I'm really hoping that that's going to help people here and now in the years coming forward, and watch the space. I hope to come back and report more on what drugs and what things we've seen that maybe can help address that.
Good afternoon, Gail. With a neuroendocrine tumor in pancreas, and my question is, all those data you're providing is for adenocarcinoma. Do you have any view on how food intake also influence on neuroendocrine tumor? Because there's a lot of debate with all the pesticide used in agriculture and how it impacts food. Do you have any data on those type of tumors as well? Too early?
It's real estate. It's honestly real estate. People will set up a study with a certain interest in things that they know about or think is promising, and whether they've collected it. But I think that's really interesting, especially also now where we have an interest in environmental impacts. I think that understanding more about pesticides in some of these areas, organic pollutants that people didn't collect the data. And I think, so for instance, we're now setting up a study and trying to collect 80,000 people with a focus on vegetarian and vegan diets. But it's exactly then, you get in and say then, hey, you're doing this, can you add these questions? Can you look into this? Because to be honest, I don't think the data are sufficient to answer that. And it's a really good question. So some of the things that aren't on that list, It's not that they're maybe not true, maybe they're just no one studied it enough. Yeah.
Hello, Julie from Luxembourg. You talked about proteins and the protein detection in the blood and proteinomics. How do you think cancer vaccines can come into this? Because I know at Oxford you're doing a lot of work on it. Does that mean you can maybe develop the preventative vaccines because of the blood test for proteins? Can you explain that?
There are groups in our sort of next building working on that, because I think a lot of these proteins are involved in immunity, and I think vaccines coming in early, targeting it early at the earliest stages is definitely part of the answer. And I know there are some works in the works right now on that. So absolutely, that's one of the spaces where, yeah, we could maybe do more in early onset. So I wish things didn't take as long, but yeah. Thanks.
Okay, so we're going to switch gears a little bit and move on to a panel discussion now. And I would like to invite 3 fellow patient advocate leaders for a little bit of a chat. And they will be talking about the importance of community education and awareness initiatives, particularly on the topic of early onset cancers. We have Sarunas Narbutas from the Youth Cancer Europe group, Dr. Lisa Wild from Bowel Cancer UK, and Victor Girbu from the EU Network of Youth Cancer Survivors. It would be great if you guys could introduce yourselves and then just kind of walk us through the initiatives that you are working on in your respective organizations. Welcome and thank you so much.
Do you hear me? Okay, yes. Hello. I'm Sharunas from Lithuania. Have been diagnosed with a rare type of blood cancer at the age of 18. So I'm 46 now. So I'm living with cancer more than I have not been living with cancer on this earth. And I'm involved at the national, European, and the global level with 3 different organizations. We will focus on one of them later in the call, but now I'm just doing an intro part. So at Lithuanian level, I founded an umbrella for all cancer patients, Lithuanian Cancer Patient Coalition, which is a member of DICE. We have 55,000 members. So that's really big. We are the biggest patient organization and one of the biggest NGOs in the country. At European level, I co-founded and am chairman of Youth Cancer Europe. This is what we're going to tap on today. Victor is from Youth Cancer Europe. He also saw more people on stage from Youth Cancer Europe speaking in here. It was Mila, it was Lasma, it was Michael, who were attending our events or part of our community. And at global level, it is for my diagnosis. So I'm living with what is called chronic myelogenous leukemia, and that is a global network, so CML Advocates Network, which is one of the biggest rare disease networks in the world. We have over 120 organizations from 90 countries, so all continents except Antarctica yet. Why this disease is relevant, it is actually is the first indication which got a targeted therapy in all of the cancer in years 2000. So what we are discussing there of targeted therapy, precision medicine, this is started with our cohort. That's why I'm alive. Before that, it was a death sentence. So what I pose here, and I think maybe we go to Lisa next.
Hear me? Oh gosh, there I am. Hi everyone, I'm Lisa Wild. I'm the Director of Research, Policy and Influencing at the charity Bowel Cancer UK. And we're a very proud member of DICE. Bowel Cancer UK have had a real interest in early onset colorectal cancer for a long time now. About 13 years ago, we started a campaign called Never Too Young, and it came about because we were hearing more and more from younger people who'd had a really poor experience in terms of their diagnosis, treatment and care. So we realised that we needed a separate or a standalone arm of our activity that was focused on the needs of younger patients. And at the heart of that campaign is a survey that we do periodically. The last time it was done was just before COVID. We had 1,000 patients complete that survey, and it gave us a really great insight into the experiences and challenges that younger colorectal cancer patients faced. right through from when they were first symptomatic to getting that diagnosis, to the treatment and care they received, and then what their living with and beyond colorectal cancer life looked like. And that campaign has allowed our organisation to embed patients into our advocacy work, our education, not only education of the public and younger people around the needs of that they are never too young to get bowel cancer, but also healthcare professionals, so we can start hopefully to move the dial on some of those conversations that we've heard over the last few days, that people can't possibly have cancer because they're too young. So it's been a very humbling experience to run this campaign. I've been part of it for the last 9 years, and it's a core tenet of what we do as an organisation.
Thank you. We'll switch to Victor, but you need to know that Victor is a very shy guy, so he will not be boasting about himself. So I have to make a bit of introduction. We actually have a big celebrity in the room, because for his work in cancer, he was really, and it's a real story, nominated, awarded as a Person of the Year in Moldova. So here, celebrity, the stage is yours.
No, thank you, thank you. My name is Victor. I'm from Moldova. I'm already 31. Thank you. So I was the EDI lead.
Explain what EDI
is. Yes. So as part of the EU CAISNet. Hello, hello. Yeah. So as part of the EU CAISNet, the European Network of Youth Cancer Survivors, there were 6 working packages. So I was leading the work package 5. We'll show you slides, lots of slides in a moment. So, and I also was leading, was one of the co-chair of the NCD working group of the Youth Council, WHO Youth Council. So I'm excited to be here and share more.
But you're a patient. Tell us, you know, what you were diagnosed with.
So I was born with kidney cancer. I also was living. So for 17 years I had kidney cancer, so that's more with cancer than without, as well as Sharona's. So at the age of 6 months old, doctors removed my right kidney, and then at 2 years old they've detected kidney cancer on my left kidney as well. So until 17 years old, I was living with cancer, and then they just cut the part with the cancer. So technically, I have less than a kidney, but now it's grown and it's working good. So, yes.
Can we go to the slides a bit? Can we put it up?
Have the slides?
So I will provide a bit of background. Can we put it up like bigger?
Yep.
So I'm going to talk a bit about why Youth Cancer Europe appeared. So before it was established, and it was established like 10 years ago, I was going to a number of these events, and it's good that there was a lot of happening in the patient advocacy field, but I was normally the youngest in the room, and I'm glad now that I'm not the youngest. I was resonating with all of the topics that are being discussed, the screening, you know, prevention, the access to therapy, palliative care, all of that. But I was thinking, no one addresses my topics. What about fertility? What about graduating from high school, from university? What about not feeling in isolation? And can you exercise and be fit? All of these topics were not an agenda item. And also, as is often the case that we heard in these past 2 days, the people were asking, and I remember the lady at the back who said, I'm on holidays, but is someone else here with a stage 4 liver cancer, and etc. So many of the people in our age group feel like that. So in my diagnosis, CML, medium age is 65, and incidence is 65,000. But for the age of 1839, incidence is 1 in 2 million. And Lithuania is a country of 3 million, so I couldn't even have a theory of finding another peer to speak with. So, but then we know there's a lot of people like me with not that diagnosis, but essentially suffering from cancer being a young age in Europe. And now we know there is 500,000 people aged 18 to 39 living in European Union right now. It's a huge number. But the problem is they are not part of patient organizations most of the time. If they get through the cancer, they want to forget about it, cut it out of their life, just enjoy the healthy life, but there's still a risk. Even if we have been in remission for many years, we can have secondary cancers, we can have late effects of therapy. So there's so many things that we don't know and are falling between the gaps of healthcare system, the gaps of society in terms of thinking where to put you. So we are outsiders. So that's we think we had to unite and form a network. So Youth Cancer Europe is a network of patient advocates through all of Europe, not EU, all. So we have people from over 40 countries who are living with cancer aged 18 to 39. That's what we consider young. So it's not a pediatric setting. And here we see early onset of colorectal cancer is below 50. That's good. So 1839 is our focus. Can we go to the next slide? So here I won't be going through all of this, but this is YCE is advocacy organization, but we focus on policy initiatives, at EU level mostly. Because at national level, it's really we are too small to even raise this because there's so many unmet needs. But in EU level, and we don't have commission people, I guess, anymore in the room, but I see that actually as of, since Europe's Beating Cancer Plan, they understood that they were not looking into young people at all. They were looking in pediatric, and they were thinking we are addressing everyone else who is not a typical cancer patient. They identified that there is a separate cohort of young people. They identified that is actually the perfect patient that you want to save. That if you do it properly, the people will live, will contribute to the society, will not need to rely on social benefits and not actually just live off the benefits, and that there's a lot of work to be done. So these are the things. I won't be going through each of them, but the activities that we did at European Parliament. We are not based, go back, we are not based in Brussels, but we see ourselves a bit as like airborne infantry. We zoom in, we say something, we zoom out, we see what happens. And actually the things are changing. So as you see, the first 2017, the event on right to be forgotten. You heard from financial discrimination from Professor François Monet. So this is what we did back in 2017 to start discussing this topic in the European Union. And François has elaborated that her work, already led to at least 8 countries in Europe adopting this change. The cross-border healthcare directive is something that impacts a lot, probably I say every young cancer patient, because in many instances you do not have a healthcare professional specializing in your disease who has an experience of treating patients like you in your country. But there are these experts in Europe, or there's these extra experts abroad, and we have a legal document, the directive from the year 2011, meaning that there is more than a decade of this directive being adopted that we can use, and still many people are not aware. There was a question, what rights do we have? There's a lot of rights for the patients in that directive. I won't be going through all of them, but you see the topics that we are working is right to be forgotten, cross-border healthcare, fertility, mental health. This CBHD is cross-border healthcare directive, TR2BF, the right to be forgotten, it's just abbreviations. And now when we go into the next slide, these are events that Victor will talk more about, that we created something practical, which we think is relevant to share with this audience today, on the specific EU level recommendations that we created as a part of EU for Health project. So it was co-funded by European Commission. We've co-created this together with leading cancer centers specializing in eye care, adolescent and young adults, and with a lot of patient organizations in there. And what is good is that Victor will elaborate where you can find them. But I think these are the practical documents. It's not a wish list of what the policy has to change. It's what actually you can do. As a patient, what you need to know, as a healthcare professional, for example, on these recommendations on equitable, diverse, and inclusive cancer care, what are the things that you are currently not considering? How do you speak with patients? From which background? Where do they come from? What do you need to do? Speak with your colleagues. So many things that I was reflecting on the questions that were asked throughout these days. Many were asking, so what do we do on this, on that topic, and expecting the answer from the stage. Very good questions, but I think the answers is like every answer could be a workshop and could be for the specific country, and we cannot have just one recipe for all. But what we are striving here in Youth Cancer Europe is to, first of all, let people feel that you are not alone. There are people like you, and there is a community that cares. And it's not always about solving the big topics. It is about knowing what is happening out there. We often think the data is not there. I'm a strong believer that it's, if you can look, if you want to look, you will find something that's relevant. So it's all about garnering that interest to speak out, to look out there, to collaborate, and then find questions for yourself. We are not trying to save the world. First, we need to save ourselves, then the next peer, and this is how we survive and build this community. Victor.
All right. So what's important to understand is Youth Cancer Europe is one of the beneficiaries in this consortium that forms EUCASNet. So EUCASNet is a project co-funded by European Commission, which unites, as I said, leading organizations from 18 countries. So all of them are active in childhood and youth cancer field, and they created EUCASNet to map existing resources, which you'll find. I have plenty of QR codes in the slides, to create new European guidelines and to create a European network of people living with and beyond cancer, to empower them to advocate for their rights. So speaking about that, here are the countries involved. We have on the website, so here it is, you can scan it already. We have a network of youth cancer survivors, right? If you want to reach out to them, you can find our community on the website. As well, there's a platform of, there's a Discord server where you can find our cancer survivors interacting, and we actually have a moderator here in the room with us. This is to create this online community for cancer support. An interactive hub where you can get the answer you're looking for, bond with your peers, and forge collaboration while having fun. You can find them all on that server. So now getting into our work. We published EDI policy recommendations. It focuses around 3 main recommendations, 26 specific actions, and it's created by young cancer survivors. There's also a practical train the trainer toolkit that is for 3 main audiences. It's healthcare professionals, patient advocates, and researchers. I know there's people that actually benefited from the trainings here. Based on patient surveys and stakeholder input from 25 countries, the paper comes with these recommendations. And again, to access the findings and recommendations, I invite you to visit beatcancer.eu. So also there were peer visits as part of work package 4, which is about adolescents and young adults. They visited hospitals in different European states. So not sure what the numbers are for 2023, but in 2022, there were over 150,000 young Europeans, 15 to 39, that received a cancer diagnosis. So these young people face challenges that often fall between traditional pediatric and adult cancer care. Through these hospital peer visits, young cancer survivors developed the recommendations for eye cancer care units. So it's a document shaped by those who understand these needs best. So if you're involved in oncology, healthcare policy, or hospital administration, I encourage you to also explore these evidence-based standards. So I'll share it one more time if you didn't have time to scan it. So please access our website, connect with our patient advocates, and explore the recommendations that we have there. Thank you.
So what I would just add that beatcancer.eu website, we actually had over 1 million visits last year through this. So and it's broader than EU, of course, because it's in English, but it has 9 languages currently. We have a plan to actually translate it to all EU languages, so 24 of them. And about this Discord group, where Mila is also a community moderator, there's over 700 advocates in there. So it's a big online community. What we figured out, like, look, these events are great, but you see it takes 6 months as a challenge to organize this, and people want to keep in touch. So it is our finding that we need to build and foster a relationship through the online medium. So we use WhatsApp groups, Telegrams, etc., but very more structured. But this is an invitation not just to the patient advocates, it's for anyone in the room, any healthcare professional, caregiver, who is interested in helping young people with cancer. So we have a separate channels where the healthcare professionals can speak with each other, ask questions differently, and etc. So we try to build somewhere, how do we map this community who is interested in helping young people with cancer, which is currently now spread out. It's there, every hospital cares for young people with cancer, but no one is really just looking into it. So we try to provide a safe space for that. So I think we stop in here. Maybe, Lisa, there's something else from your side that you want to share.
Yeah, that was fascinating. Thank you. And it was really interesting to hear you both talk, because I could see a lot of synergy between the activity that you have here going on with your organisation and what we've done in the UK. I think what was fascinating when we started working really closely with younger colorectal cancer patients is we saw there was like a number of really niche areas that we needed to support them with, but actually to create safe and held spaces for them to do their own advocacy as well, that it wasn't just they needed us to parachute in and tell them what to do or tell them what the most important areas they should be focusing on. So we very much in similar have an online forum which has a dedicated space for younger patients where, and I would urge any of you to go and have a look at that and drop in if you want to see what the kind of state of younger patients or what they're experiencing in the UK, that is a great place to go. But then again, we decided that the younger patients element of our work in terms of advocacy, there were some really clear places that we needed to go. So one of those was around that issue of patients presenting at their GP and not being taken seriously, told they couldn't possibly have cancer, or quite often they would get diagnosed with a related bowel condition, but it wasn't bowel cancer. So we've advocated really strongly, and with the help of patients beside us, we now have guidelines in the UK for how younger patients, people with bowel cancer symptoms should be referred. We've done a lot of work on what we call fit-in symptomatics, so the fit test being available for GPs so they can rule out or rule in bowel cancer first and fast. And we are starting to see a definite uptick in the way that people are being taken more seriously and referred. But yeah, we've still got a long way to go, but I think having patients at the forefront of the work we do is absolutely critical to that.
I see that the time is up, so I don't know with Natasha, do we ask for questions?
Yes, I think we do have time for a few questions. And just so you know, we will post all of the links and the resources on the ENTERO website so that they can be accessed after the event.
We do have a question.
I see the hand in front of me.
Yeah. Nicola, right there.
Hello.
Oh, can't hear you. No.
Is it working now?
Oh, yeah.
Sorry. Yes, I don't need to yell. Yeah, sorry, I just noticed that on the video on the background there were lots of different countries and flags, obviously. And because I'm from Finland, and I noticed that there's a Finnish flag there. There were two girls waving it, and I noticed that there's no Nordic countries are not painted yellow on your map. So what's happening with the Nordic countries? Why there's nothing, but there's still some flags are swinging
Exactly.
there?
Great question. So as you see, these are the member of organizations who are part of the project, so meaning organizations. And this is, the video is from the last big event that we did in August, bringing the survivors, cancer survivors from each EU member state. So that's where you see the flag. So essentially, yes, we need to have a stronger collaboration at the organization level with Scandinavian countries, which we don't see. We know that there's like Ung Cancer in Sweden, organization in Finland. I don't know if you know of someone who is working in the field of young cancer. Let's talk. With Norway, it's the same. But again, for us, this is particular to one EU co-funded project, which we are part of. There's other patient organizations involved in this project. And Youth Cancer Europe, as I told you, is about bringing every member of in Europe, and that would be a different map. With YCE membership, we would have 46 countries currently, including all EU member states where we have active advocates from.
Thank you so much. I think we will now take a short break. The speakers will remain here in the room or at the coffee break for you to continue asking your questions, and then we will return for our concluding remarks. Thank you so much, guys.
Thank you.
Yes.
Try to tell what you were thinking.
matter what we go through, love will still remain. So do what you want, baby. You and me in the sun. Know that I still be here when the day is done. So come a little bit closer, and I'll tell you what I feel inside. You know I'm gonna wait on you. I'm gonna wait on you. You know I'm gonna wait on you. Yes, I'm gonna wait on you. No one's gonna love you like I do. So glad that I found you. You're the missing piece, the last piece of the puzzle. I'm finally at ease. So when times are rough and the promises we make just seem so hollow and weak, and we're about to break, we have to remind ourselves, 'cause we know how we feel inside. You know I'm gonna wait on you. Ain't over till it's over. I'm gonna wait on you. I'm gonna love it till it's gone. You know I'm gonna wait on you. And the weight that's on your shoulder, I'm gonna carry that for you. So hear me when I say, no one's gonna love you like I do. I'm gonna wait on you. I'm gonna wait on you. I'm gonna wait on you. You know I'm gonna wait on you. And the weight that's on your shoulder, yes, I'm gonna carry that for you. So hear me when I say, no one's gonna love you like I do.
Let's fly away, just you and me. I need a little break from the city. It's been so long since we've been gone. I wanna feel that summer feel, but I don't wanna go if you ain't with me. Let's make a home, be all alone. So tell me, baby, where would you like to go? Maybe we'll drive from coast to coast, only to where we love the most. I'm taking you to paradise, paradise. You know where we're going tonight, going tonight. Paradise, paradise. I'm taking you to paradise, paradise. I don't even care about the price, care about the price, yeah. Paradise, paradise. I'm taking you. Let's see the sun and have some fun. I'm so tired of living life in gray, babe. And you deserve to see the world. So tell me, baby, where would you like to go? Maybe we'll drive from coast to coast, only to where we love the most. about the price, yeah. Paradise, paradise. I'm taking you. Come and take a seat next to me, babe. Let this pretty view take your breath away. Baby, we deserve a break from our old ways. Anywhere's home when you're with me. Come and take a seat next to me, babe. Let this pretty view take your breath away. Baby, we deserve a break from our old ways. Cause I'm taking you to paradise, paradise. You know where we're going tonight, going tonight. Paradise, paradise. I'm taking you to paradise, paradise. I don't even care about the price, care about the price, yeah. Paradise, paradise. I'm taking you, paradise.
Ever since we met last night, I've been trying to keep my distance. I just wanna play my cards right. It takes one false move and you'll be gone. But maybe it's alright. I can't tell if it's the right moment, but baby, anyhow, I can't hold it in anymore. Cause it's starting to come out, starting to come out. I've been holding it for too long, too long. Yeah, it's starting to come out, starting to come out. And I can't pretend anymore. Oh, I'm yours. Never thought I'd even try. After just one day, it's special, yeah. But there is something in your eyes. Ooh, one false move and you'll be gone. You maybe it's alright.
Yes.
I can't tell if, baby, it's the right moment, but baby, anyhow, I can't hold it in anymore, no. Cause it's starting to come out, starting to come out. I've been holding it in for too long, too long. Yeah, it's starting to come out, starting to come out. And I can't pretend anymore. Ooh, I'm yours. Starting to come out, starting to come out, starting to come out. Ooh, I'm yours. Starting to come out, starting to come out.
I long for that feeling. Why did it have to go away? I long for that feeling. Remember everything you said. Had to go on dreaming, dreaming. 'Cause baby, you are everywhere. I wish that you were here.
still wanna turn up. Yeah, I still wanna turn up. All I want is to go again, but you ain't picking your phone up. Why you messing my head up? Any night, any day, let me take you away. All I need is just saying yeah, 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 yeah. Better nights, better days, when you're here with me, babe. Cause you're all that I crave, so I wonder, where are you? Where are you? Where are you? Don't hide away from me when I need you most. We got love guaranteed, and I have to know, say,
Hello everyone, good afternoon. I introduce you now Marta Temido, member of the European Parliament and former health minister.
Thank you so much. Good afternoon, ladies and gentlemen. I want to start by thank you, Europa Colon, Portugal, for the invitation to this meeting. It is a great honor to be here as a member of the European Parliament and as a Portuguese, as a health manager from an oncological institute here in Oporto. So this is like coming back home again. Thank you for this opportunity. I would like to say a couple of ideas about the European strategy for cancer, in order to answer to the question that you present me. I would like to remember you that in 2021, in the aftermath of COVID-19, the European Union launched the European Beating Cancer Plan. In that moment, President von der Leyen stressed that in 2020, European Union had lost 1.3 million Europeans to this disease, and that, sadly, the number of new cases was still rising. The plan has 10 flagship initiatives and multiple support actions involving funding of 4 million euros. It aims to tackle the entire disease pathway using a health in all policies approach, as a broad array of European Union policies will support implementation, namely education and employment, agriculture and environment, or research and taxation. The plan was structured around 4 key action areas where the European Union can add most value, while fully respecting Member States' responsibilities in health policy. Please remember that according to the treaties, Member States are responsible for the organization and delivery of health services and medical care and for the allocation of the resources assigned to them. So those actions that are considered in the European Union Beating Cancer Plan are for prevention, early detection, diagnosis and treatment, and quality of life of cancer patients and survivors. The plan contains concrete ambitions that will support, coordinate, and complement Member States' efforts to reduce the suffering caused by cancer. It uses the unique convening power of the European Union, fixing goals, setting clear deadlines, committing the necessary funding, and connecting the main actor through effective partnerships. The implementation power is currently in Member States' hands, and this is very important. So let me briefly use my time focusing in one of the areas of Beating Cancer Plan where we absolutely need to move forward in implementation, forward and faster. It is prevention and early detection, in my perspective. Prevention, of course, is more effective than any cure. About 40% of cancer cases in the European Union are preventable. Prevention is also the most cost-effective long-term cancer control strategy. We have to raise awareness of risk factors such as smoking, harmful alcohol consumption, obesity and lack of physical activity, exposure to pollution, carcinogenic substances and radiation. We also need to address health determinants, including education, socioeconomic status, gender, age, and employment. And we have to pay attention to inequalities in access to prevention, affecting, for example, elderly people, people with disabilities, or minorities. It is of the utmost importance to give citizens the information and tools they need to make healthier choices and to prepare patients on how to live well after cancer treatment. Two examples. The mobile app for cancer prevention is an example, a good example, I think, of actions developed by the European Union to improve healthy behaviors. But also the dissemination of the European Code Against Cancer, with its evidence-based recommendations to improve health literacy and with information on how to benefit from new developments in personalized cancer risk assessment, is another one. Now about risk factors. Tobacco consumption. Tobacco consumption continues to be the leading cause of preventable cancer, with 27% of all cancers attributed to tobacco use. We have created a tobacco-free generation where less than 5% of the population uses tobacco by 2040, compared to around 25% in 2020. The European Union institutions have to review and update directives and recommendations on smoke-free environments, especially extending its coverage to emerging products if they want to achieve those targets. Another risk factor, alcohol-related harm. Alcohol-related harm is a major public health concern in the European Union. Member States need to reduce harmful alcohol consumption in line with targets of the United Nations Sustainable Development Goals. This includes a target to achieve a relative reduction of at least 10% in the harmful use of alcohol by 2025. In addition, the European Union must continue to invest on the revision of the legislation on the taxation of alcohol and on introducing a mandatory indication of the list of ingredients and the nutrition declaration on alcoholic beverage levels. Addressing unhealthy diets and physical inactivity is another key area of prevention. For instance, addressing obesity and diabetes for the strategy for farm-to-fork strategy is very important. And the revision of the European Union School Fruit, Vegetables and Milk Scheme is under development. But the strategy farm-to-fork also refers to sustainable production and consumption of food. And in line with the shift to a more plant-based diet, with less red and processed meat and other foods linked to cancer risks, and more fruit and vegetables. And we are all aware that investment in active mobility infrastructures and healthy canteens, as well as taxation measures, can also help with health promotion. I will not go into detail about other measures, other preventive measures, but I want to stress that many of these risk factors are linked to important economic and commercial sectors, and several times this causes constraints. To conclude, early detection. Early detection through screening offers best chance of beating cancer and saving lives. As of 2020, 25 member states had introduced in their national cancer control plans population-based screening programs for breast cancer, 22 member states for cervical cancer, and 20 for colorectal cancer. However, many programs have not been fully implemented and inequalities persist within countries and between countries. The Europe's Beating Cancer Plan had put forward a new European Union-supported cancer screening scheme to help member states ensure that 90% of the EU population who qualify for breast, cervical and colorectal cancer screenings are offered screening by 2025. The scheme is, of course, supported by European Union funding and focus on making improvements in 3 key areas: access, quality, and diagnostic. So, dear friends, cancer is a diagnosis that has important impacts on individual patients in several of your lives. But it is also severely affects the lives of your families, of the families of patients, and of friends of patients. Moreover, it affects society, as the overall economic impact of cancer in Europe is estimated to exceed 100 billion euros annually. Unless we take decisive actions, lives lost to cancer in the European Union are set to increase by more than 24% by 2035. So today you asked me, how can we move forward? My answer is crystal clear. I would say that we need to assure the implementation of Europe's Beating Cancer Plan with these key areas of investing in diagnostic and treatment, in quality of life of patients and survivors, and especially in prevention. This will continue to require bold leadership at the European Union institutions level, able to bring member states and citizens together, setting out the direction of travel and building public and political support. And I think that initiatives like ENTERO 2024 are very important contributions. So again, many thanks to your support, many thanks for being here, and many thanks for inviting me to share this last session with you. Thank you.
And now we'll hear the Secretary of State for Health, Professor Anna Pope.
Ladies and gentlemen, first I would like to present my special compliments. I know that he's not today, but I need to speak about him. Engenheiro Vítor Neves, President of Europa Colon, for the invitation to be here today. Greeting to the entire panel of this session that is here today with me, but a special to Professora Marta Temido, former Minister of Health of Portugal. To tackling this problem, we need to focus on 3 main areas: early detection and treatment, prevention, and also support for survivors. Early detection is the key. Digestive cancer are often hard to spot early, but early detection means more effective treatment. By investing in screening programs and improving awareness, we can give young people a fight chance. We need more funding, and we need to educate healthcare professionals and the public about the importance of early screening. Awareness isn't just a goal, it's a tool that saves lives. In fact, boosting cancer screening programs is one of the priority measures identified in both the government program and in the Minister of Health Emergency Plan. We are currently working with the Director General of Health and also with the Executive Director of SNS to restructure the governance of this program, thinking a vertical, harmonized implementation through all countries, with the aim of increasing both geographical coverage and adherence to breast cancer, cervical cancer, and colorectal cancer screening. And why we do this? Because in Portugal, until now, they are very important reference geographic in the adherence to the screening. Screening in oncology is the key for success. For the Ministry, oncological disease and their prevention are a priority, which is why we also recently announced the extension of starting age of breast cancer screening to 45, and we plan to soon implement a pilot for lung cancer screening. And we still working together with the Director General for Health to work with implementation of more screening programs whenever they bring health gains to the population. Prevention is also critical. We can lower the risk of digestive cancer through health habits and lifestyle change, but people need to know what step to take. Education on nutrition, exercise, and the risk associated with certain habits can have a huge impact on prevention. At the same time, we must continue to research why these cancers are affecting young people and find ways to reduce the risk at the population level. By prevention and detection are only part of the journey. For those who survive cancer, the path forward is not always easy. And regarding to digestive cancer, this is really true. I am a surgeon and I will be always a surgeon, and we speak a lot about the quality of life of the patients that survived rectal cancer and the treatments they need to pass and impact in their lives. Survivors may face new health challenges, including ongoing physical issues, mental health struggles, and financial strains. Cancer can be a long, painful journey, and it doesn't end with the last treatment. Many survivors need regular checkups, mental health support, and assistance to returning to work or school. And we know it's our responsibility to create a healthcare system that supports them fully from the moment of the diagnosis through the years after recovery. As we live here today, I ask each of you to keep pushing forward. Let's work together for a future where digestive cancer in young people are here, where early detection is the standard, and where survivors are supported every step on the way. This government has a strong commitment with oncology, proven by our actions, be with screening programs or with the treatment, just as the new proton therapy center coming to IPO Porto. We will continue to strive for improvements, and I ask you to keep doing the same. The path may be long, but every effort we make brings us closer to that future. Thank you for your time, your commitment, and your partnership. Together we can make the difference. Thank you very much.
Thank you. I want to thank Professor Marta Temido and Professor Ana Povo for coming here and joining us at this important event. Now we will have a quick session to wrap up on how to move forward, and I would like to invite a friend to come to this stage. Andy, the floor is yours. Thank you.
Thank you, Zorana. 140 heartbeats just for walking from there to here. Hello, everyone, and thank you for still being here. I'm grateful to be here in Porto, and it's a privilege to stand before you all, and I really mean it. As some of you know, I'm here today not just as a patient advisor for Digestive Cancers Europe, but also as a cancer patient myself. In 2019, I was diagnosed with stage 3 colon cancer. At that time, I was 36 years old. It was a life-changing moment, one that no one expects to face in their 30s. 1.5 years later, it metastasized to my liver, and I had to go abroad for a very complicated surgery. Although I was terrified, I was lucky enough to be able to take my daughters to their first day of school, one day before flying to Germany. Another 1.5 years later, it relapsed, so I have to leave my girls again, and my rabbit, and take my chances with another life-threatening surgery in Germany. Being promoted to stage 4 cancer, today I undergo palliative chemotherapy every 2 weeks for the rest of my life. It's not a conclusion, but a way of managing life with cancer. The journey through the disease has been long, 5 years of fighting, including 6 months of chemotherapy, 3 complex surgeries across 2 countries, and another 31 rounds of chemo. But the fight goes on, navigating the ups and downs of this journey with the support of my family, my friends, and the medical community around me. When I first began my treatment journey, there wasn't much discussion about treatments being tailored to the individual patient. To be honest, not much was being said in general. There were 3 doctors who were very quick to diagnose me with anemia because I was 36 and I looked too young to have something more serious than that. They recommended that in addition to blood tests and ultrasound, to also have a colonoscopy, but none of them explained to me how the colonoscopy is actually done, how important it is in the diagnosis process, and how little bothersome it is as a procedure itself, because the name is pretty scary. My lack of medical knowledge, fear, and shame caused me to put off the colonoscopy for more than 6 months. I will never know what my life and my battle with cancer would have looked like if I had done it half a year earlier. But in recent years, there's been a shift toward personalized care, where treatments are matched to each patient's genetic profile and specific needs. This focus on genetic markers, targeted therapies, and precision medicine has been a real game changer for cancer care, giving patients a more individualized approach that offers new hope and possibilities. The truth is, as patients, we want testing and treatments that fit us like a glove. Personalized medicine is offering that, but there's a catch. It is only great if you can actually get it. In Romania and in many other parts of Europe, not everyone has access to these cutting-edge treatments. It is essential that patients are educated about these options, informed of their rights, including the possibility of seeking a second medical opinion, and empowered to advocate for their own care. Sadly, there are still lots of doctors who see the request for a second opinion as a personal affront, an insult to their status and training, and this must stop. We need to work together to ensure that every patient, no matter where they are from or what their background is, has equal access to these life-changing treatments and to the best possible care. One of the things I've learned in this journey is that patients are often left out of the conversation when it comes to research and policy making. That is like being invited to a dinner party, but told you can only watch everyone else eating. Not very fun, right? I believe that patients should have a seat at the table when it comes to clinical trials, research design, and policy decision making. After all, we are the ones living with the consequences of these decisions. We need to make sure that the treatments being developed reflects our needs and priorities. That means extending the conversation beyond just prolonged survival, aiming for the best possible care and quality of life. It's about how we live and what kind of life we want. If patients are part of the process, we end up with solutions that work for us, not just for researchers. I want to use this opportunity to thank DICE and the whole team for their huge efforts and for being one of the most important platforms existing in Europe for fostering a space where ideas become action, and making great efforts to ensure that the voice of patients is heard. I'd like to wrap up my speech today by addressing the importance of support, because trust me, we all need it. Living with cancer isn't just about the physical symptoms, it's about the mental and emotional roller coaster that comes with it. I learned that you can't just treat the disease, you have to treat the person, and I'm very happy that I have heard this sentence here today several times. That's where holistic care comes in, whether it's mental health services, financial support, or just knowing that someone gets it when you say you're having a chemo brain day. These things really, really matters, especially for younger patients who have long roads ahead of them. As I said, I was 36 when I was diagnosed with 2 beautiful little daughters. Trust me, there is no guidebook on how to explain having cancer to your kids, and there is definitely no manual on how to manage the emotional toll it takes on you as a parent. There is no right age to get cancer, but for young patients who are in their career's apogee, who are the main income generators for their family, the struggle to keep their jobs and income levels, the fear of getting fired once they stop being productive, or when their performance decreases due to aggressive treatments, are huge burdens, almost impossible to be carried out alone. On top of everything, more than 50% of cancer patients are fighting with depression, anxiety, PTSD, or adjustment disorders. Holistic care needs to address these changes as well. Cancer isn't just about surviving, it's about living, and the better we support patients beyond the medical treatments, the better chance we have at living fully. Despite the cancer. Yeah, that was exactly what I said. So here I am standing before you, still fighting for survival and as a patient advocate for other patients' lives. And if there is one thing I want you to take away from today, is this: we, the patients, deserve more than just good medicine. We deserve access to the best possible care. We deserve to be involved in decisions about our health. And we deserve support that sees us as more than just a diagnosis or a number in a medical chart. Before I close, I want to take a moment to speak about something very dear to me, a project that has given a voice to young adults facing colorectal cancer. The book, You're Young, But It Might Be Cancer, shares the stories of 16 young adults who, like me, were diagnosed with colorectal cancer far too early in life. We each opened up about the challenges, the fears, and the hope that came with this journey. It is a reminder that cancer doesn't discriminate by age, and that young people are grappling with a disease often assumed to affect only older adults. Being part of this collection was both humbling and empowering. It is a raw, honest look at what it means to face cancer at a young age, from the struggles and fears to the resilience that keeps us going. Sharing my story alongside so many incredible individuals reminded me why I continue to fight for better care and support for all patients. But today, as I stand here, I speak not just for myself, but also in the memory of 2 of our fellow contributors. Sadly, Helen from the UK and Luca from Italy have passed away. Their stories, like all of ours, were filled with resilience and strength, and their loss is a reminder of the stakes in this battle. We are more than statistics, we are people with lives, families, dreams, and struggles. So I would like to dedicate my speech today to their memory. As we push forward in our advocacy for personalized and equitable care, we must not forget the real faces behind this fight. Let's honor their legacy by continuing to demand better care for all of us, making sure no one feels like they are battling this disease alone. I'm grateful to be part of this dialogue and hopeful for the future we are building together, a future where no patient is left behind. Thank you for listening, and remember, laugh often, even when it feels impossible, because this is also what gets me through. Thank you.
Thank you, Andy. Thank you for being together with other patients that are in the room, the inspiration for us and for giving us strength to continue and make sure that no patients are left behind. Now, I would like to invite Dr. Jose Perea to give us his view forward from the medical perspective.
Thank you.
So, thank you very much, firstly, DICE, for inviting me to this great and essential event. And of course, all the patients, because I've been connecting with different patient associations around the world since more than 5 years for changing our point of view and perspective from this disease from a clinical and research point of view, because I think all of you are essential, and it's proof with this type of meeting. So I have to summarize more or less in a short term this presentation. I'm going to develop these 4 topics regarding the perspective in the future that is going on early onset GI cancers. I'm going to develop these 4 topics. Firstly, specifically for research, this could be a summary of the current state of the art of what's going on early onset colon cancer, colorectal cancer. So, and hopefully, and in perspective, in a few years, is going to be more or less for the rest of the GI cancers that are diagnosed in early ages. So, if you can see in the presentation in the slide, I think early onset colorectal cancer could develop from a predisposition. Then it is that some of the environmental stages are impacting in the state of the person, and then you will get inflammation, altered immunity, chronic acquired conditions, and finally you will get this cancer. So from this point of view, another topic that is arising specifically in early onset GI cancer is disparities. As you can see in the slide, this is a summary of the huge number of disparities that could be connected with this type of cancers, not only from a perspective of the individual factors, not only from a perspective of biology and genetics, but also the environmental and the system and institutions. So this is getting difficult, but also this is going to give us different clues about the solving this problem. Taking this specific characteristic from early onset GI cancers, when we afford the research of this subtype of cancers, we should take into account the disparities, not only from the different point of geographical areas, but also from ethnicities. And also, if you can see in the slides, we should take into account late onset colorectal cancer, because I think nowadays, this is our work that was published 10 years ago, and we thought in that occasion that early onset colon cancer could be a different subtype of colon cancer. And I think, seeing all the years that it's been evolving the research, it's proven that maybe not completely, but also there are differences, and maybe not only from colon cancer, but also from all of the GI subtypes of cancers. This slide is only to summarize that early onset colorectal cancer is the one that is more evolved in the research, in the management, but this is not because, for example, tricks or whatever, because this is the most frequent cancer that is in GI subtypes, and of course being the most frequent and being the one which is screened, so the evolution of the research is more advanced. But I think we all, researchers and clinicians, we should put all the GI cancers to try to get the solving problems of these early onset GI cancers in the same direction, not only colon cancer, but also gastric cancer, pancreas cancer, esophagus, appendiceal also, so put together in the same level. taking on account another topic is personalized medicine and target therapies. I think nowadays we are evolving not only in a global treatment, but also a specific treatment for specific subtypes of tumors. You can see in the slides the space of the liquid biopsy and also the target therapies specifically, for example, for immunotherapy, etc. Not only that, but also if you have been from yesterday to today, we have seen that this subtype of cancers has got a lot of specific characteristics. For example, thinking about the reproductive health and also sexual activity, and also a lot of things regarding, for example, stomas. So we should afford that as clinicians or as researchers think about that problem. Thanks that things are evolving, and we have different approaches, specifically, for example, for early onset rectal cancer. Of course, globally, rectal cancer. This slide is to summarize specifically those immunotherapies that are specifically in MSI rectal cancer that are getting a lot of interest in the last few months, and also the approach for watch and wait that are for those rectal cancer that are in advanced stages and should be with neoadjuvant therapies, and sometimes you could avoid the surgical approaches, and of course all the impact that has got that surgical approach for people, for example, stomas, etc., sexual activity, and also finally with this topic, I don't have to forget because of course I'm colorectal surgeon, that in the last few years the surgical approaches are evolving so fast. This is a revolution because of the minimal invasive surgery. You have not only laparoscopic but also robotic that is getting a very important impact in the quality of life of people that, for example, have got rectal cancer, and of course, again, more specifically for early onset colorectal cancer. What should we do about the research in this subtype of cancers? I think global collaboration is imperative. We have seen around yesterday and today that this subtype of cancers, early onset GI cancers, are a worldwide problem. And not only that, but also the frequency, the different aspects of this subtype of cancers are different from around the world. Taking on account, again, the disparities about, for example, ethnicity, races, etc. So these are two examples of works that has been published recently that shows the importance that we should make a global approach, a worldwide approach regarding, for example, in the right side of the slide, these are the differences profiles regarding molecular approaches that are, for example, if you take on account different ethnicities, specifically in the USA. On the left side, this is a work that we have recently developed, and we have compared different regions in Europe, and again, but in this approach was only from a clinical approach. There are different phenotypes if you compare different countries around Europe, and not only that, but also if you compare different whole regions of Europe. So again, this approach, the approach that we should develop in the very near future, should be a worldwide approach in order to develop not only the common alterations, but also the differential alterations that are underlying this subtype of cancers. And finally, I think it's important that we should think about the gap between research and clinical practice. And in this specific category, I think all of you patients and patient societies should be in the first line to keep in mind and to solve the gap that is still nowadays in this topic. This is a work that we published last year. It was completely amazing because me, as a clinician, as a surgeon, I connected with 2 colon cancer patients. This one was the second one was an early onset colon cancer, Lynch syndrome, and the other a colon cancer, early onset colon cancer. And we developed a work trying to review the state of the art of early onset colorectal cancer, but from different point of views. I mean, for example, it's very known that if you see revisions in the literature, all of them are developed by clinicians, by researchers, but in this work, we try to fix which one were the difference, which one were the important thing for patients that are still not covered by the researchers and the clinician. I think for me it was a pleasure to find all these results. Another point should be a multidisciplinary approach developed, and interesting if you make a exploration in Google. For example, in the left side, you see, okay, multidisciplinary, you have the oncologist and all the medical approaches that you have, nothing about patients. This slide is from 2 years ago. So again, we have an important gap that in the literature, in internet, there is still the role of the patients, specifically, for example, for multidisciplinary approaches. On the right of the slide, you see the patients is in the middle, but not actively. So I think the thing that we should modify is that the patients should have a key role in all the decisions from around his treatment, his diagnosis, his follow-up. This covering the gaps that are connecting with research with clinicians. These are the main gaps that are still being developed nowadays. And again, patients should be in charge of at least help to develop these gaps. Specifically for early onset GI cancers, this is an interconnection between all the phases that is still in every cancer: prevention, early detection, outcomes, and therapeutics. But I think early onset GI cancers have got specific interesting characteristics. For example, thinking about the screening strategies, this subtype of cancers are not covered normally with the screening strategies unless you have family history or unless you are an hereditary forms of cancers. But if not, the screening strategies still remain uncovered. And again, quality of life and survivorship, we know, and more since yesterday, that the follow-up of this type of people are a long-term survivorship. So mainly you have keep in mind that not only you finished in 5, in 10 years, but also from along the life, just thinking about all the points that could be developed. Finally, if you cover a gap, sadly, you will have another gap immediately, more or less. This is an example of that. This is a study that hopefully we are going to publish in the very few weeks. And in this specific work, we compare in Spain, in our consortium from early onset colorectal cancer, we compare cases, Spanish cases, with the migrant population that have reached Spain. And if you see in the slide, firstly, you have a different phenotype if you compare Spanish in origin compared with the migrant people. But more reliable is the comparison that we made if comparing the period of time that those migrant people has been in Spain. You know that in Spain there is a universal health system, so it covers for every people. But if you see in the slide, if you take 10 years before and 10 years after arriving in Spain, the stage, the diagnosis is completely different for those people, and the prognosis factor is still worse if you take on account those people that have arrived 10 years or less in Spain, and those are not covered by the Spanish health system. So again, you cover different gaps, and then you will find another gap. So finally, to end the presentation, I think this is a global effort. You have to take on account that this should be a multidisciplinary approach. Not only that, but also take it globally, worldwide approaches, and also not only think about colon cancers, but also all subtypes of GI cancers, and thinking about disparities that I have shown before. And finally, again, I think the Patients Advocacy Association should be in the first line of solving this problem. Finally, I want to thank all the collaborators, all the consortium, and of course, all the associations, specifically DICE, because this is a great effort and should be in continuum. Thank you very much.
Thank you very much. Thank you everyone for being here. I represent Vitor Neves, Europacolon president. He isn't able to be here today due to health conditions. It has been an honor to welcome you in Oporto and to be a part of this amazing conference. Over the past 2 days, we have learned so much from one another. We have heard about the latest research, new treatments, and the unique challenges faced by young people with early onset digestive cancers. Most importantly, we have listened to the personal stories of patients and their families. These stories remind us why our work is so important. I hope that we've discussed here will stay with you. We would like to thank everyone who helped us make this event possible. Vitor Neves, President of Europacolon, would like to thank our team, especially André and Edith. Thank you to the European Commission for supporting this event and to Thomas for guiding us through. Thank you to the amazing speakers, participants, and everyone who joined us online. Thank you to the DICE team and congratulations to Zorana, CEO of DICE. We worked together for more than 10 years. Thank you again to Ana Povo, Secretary of State for Health. We hope that this theme can be included in our next hearing, suggested by herself, about the prevention and early diagnosis of oncological diseases. Thank you, Marta Temido, a different political that has done an amazing work as health minister in the COVID time. We hope that these issues have your continuous interest regarding the next politics to be defined and implemented. Finally, we want to thank the patients, survivors, caregivers, and their families. Your strength and courage inspires us all, every day. Let's make the patient communities have a voice in the health world and be heard. Let us continue in this fight for the prevention and early detection of these oncological diseases. Everyone who is born, wherever they are, whatever their skin color, always deserve to have the best conditions and care. Let's all fight for it. Thank you for joining. And now we have DICE founder, Professor Eric Van Kutsum.
Thank you very much. I don't have slides. Thank you very much. I will be very brief. I didn't prepare any specific topics. I just wanted to say that this was a remarkable meeting. When we started indeed DICE in 2018, so 6 years ago, we had a clear vision, we had a clear goal. That's described. And then we created a team with that, and we have exceeded our expectations, clearly. And that's one of the successes, amongst others, that we've been doing in DICE is this meeting, ENTERO, number one, I would say, ENTERO 2024. I'm sure that's not the end. Of course, everybody here is enthusiastic. That's what I could hear, that's what I could feel, with the integration of patients, healthcare professionals, with different background, politicians, the European Commission, other healthcare decision makers. So this integration is crucial and is important if we want to go forward. To support so that also physicians and scientists, that in fact you can pave the way also for physicians and scientists. Science and innovation is crucial, and that's also what the European Commission knows in the setting of other projects. That's also what I foster clearly, is that innovation, creativity is important in order to make progress, but integration at the different levels with the different stakeholders is so crucial. And this meeting is really, therefore, let's say, shows that this is possible. As DICE, as one of the DICE founders and as DICE board member, I think it's important that we now do next steps. that we sit together, that we take some take-home messages, some work to do for the future, so that it doesn't stay with a 2-day excellent event where everybody is happy and goes happy home. So we will for sure do and work on next steps and possibly, probably also on ENTERO, as was said already by Zorana, ENTERO 2.0 in the near future. So I want to congratulate everybody, the DICE team also, especially Zorana, Natasha, and the whole team. Not mention all the names in order not to forget somebody, but the whole team working on this. Congratulate, thank you, and I hope that you will further give feedback, that you will tell us what we can do better, because of course telling us that it's good is everybody is happy with that, but we want to improve, we want to take actions for the future. That's the only way that we can do better patient care, because that's what we all are here about, that's to improve patient care. Thank you so much.
Thank you, Eric. Okay, and now I think it's time for us to close the conference. So thank you all. I think that the last 2 days have been very inspiring. I know that I'm leaving Porto inspired and energized by hearing all this, and I hope and I wish and I know that within DICE we will do whatever it takes not to lose this momentum. As Eric said, it's not just, the idea is not just to organize 2 beautiful days in Porto. We have to think of the ways how to move forward and how to already present some results for ENTERO 2.0 that we plan to organize in 2026. I think it's really exciting. I think that ENTERO went beyond our expectations. We have participation from all around the world, online participation, including Algeria, Brazil, India, Malaysia, Mexico, Australia, and more, which shows that when we unite across borders, we're truly stronger, and it shows that early onset digestive cancers are a universal problem. And now I will go to a long list of thank yous. So first of all, I want to thank Europa Colon Portugal for agreeing to join us on this endeavor. It was a very short time for our 2 organizations to organize this, but Victor, Sofia, and Edith, thank you very much. You have been a great support in this, and we wish Victor best of luck with his health. Then I want to thank the European Commission for co-founding this event and to our project officer, Thomas Knuksta, for your support. We really appreciate it. I want to thank ENTERO External Advisory Board, made of patients, carer, research, and clinicians. Your vision helped shape our agenda, and I want to thank you, Professor Van Kutsem, because you helped us finalize the agenda, and your advice and expertise were essential in this also. It helped that within your phone you had a lot of names and suggestions. So thank you to all our speakers from traveling from near and far to be part of this important dialogue. Also to our online participants from over 85 countries, thank you for being with us online. Thank you to DICE team. You did an amazing job for putting this conference in just 6 months. Thank you to Natasha, Ruel, Luca, Laura, Ghislaine, Lily, Mariana are online, Ivan and Nicola are here, and Anna, thank you. Anna has been very instrumental being our Portuguese person living close to Porto. Have I forgotten somebody? No, good. And most importantly, I want to thank once again to the unbelievable patient community, patient and care community that we have. You remain our why. And thank you all for being part of this incredible journey, and safe travels home, and stay tuned for ENTERO 2.0.
When you show the way, yeah, 'cause even if I fall, ooh, I trust you'll stay. To learn how to see what you already saw.